All right, going to kickstart the first session, and Elena, over to you, and when it's appropriate we can just say to them to put their cameras on.
Yeah, absolutely, that's fine. Thank you, thanks Jackie. So we've got a wee bit of a mishmash today for the pharmacy updates. We've got 4 different topics to go through with you. So they're all fairly short presentations, but I'm happy to answer any questions you have at any point. Just put your hand up and we'll sort that out. So the first one is a general update on the pumps, which are so important to us. There have been quite a few changes over the last few years. There's been quite a few warning notices that come out about the pumps as well. So just want to make sure that you're up to date with all of that. Just wait for it to be loaded. Is that okay now?
Yeah.
Yeah, okay. Full screen. Technology. Okay. Thanks, Jackie. Next slide, actually. So just a wee reminder, first of all, that we do have a guideline on use of the pumps, and it is the guideline that's specifically about the technical use of the pumps. It doesn't have any medicines information in it. That guideline is purely on how you use the pumps, how you set them up, how you monitor them, how you troubleshoot, etc. So it's always been available online on the Palliative Care GGC website, and it still is available, but we also have lots of printed copies that are available. So if anybody needs any printed copies, I just ask myself or Susan Addy or Carolyn Mackay. We've all got lots of copies of that. The guideline is in the process of being updated because of the new pumps that we have, and we'll come back to that later on. Next slide, please, Jackie. So just to run you through all the various bits and bobs that have come out from CME and then BD recently about the pumps. There have been various safety notices about the use of the pumps over the last few years, and the first main one was back in 2015, which sounds like a long time ago now, but it was a general warning about protecting the pumps from direct sunlight, and that's something we shouldn't be doing anyway. We all know not to put the pumps into direct sunlight because it has an effect on the medicines potentially, and it can cause chemical reactions within the syringe itself, but it can also cause a problem with the pumps. And it was actually an issue that was identified not with the T34s that we use, but with a bigger device which is called the T60, but they're basically made from the same types of plastic. So the company made the safety notice applicable to both devices. And it was to do with the fact that if you put the pump into direct sunlight, not surprisingly, depending how strong the sunlight is, the plastic casing, the plastic housing inside the pumps will start to heat up, and it can cause the pumps to actually switch off completely. So it's a general warning. It should be something you're doing anyway, and the rule of thumb is that if the patient is out and about with the pumps, they should always have one of the protective pouches over the pump. And obviously we would never encourage people to sit in direct sunlight with the pumps because that would potentially cause problems as well. Next slide, please, Jackie. So then we move on to 2018, and this was when we had the first warning about potential battery issues with the pumps. And the company highlighted then at that point that this was at the point where we used lots of different types of batteries with the pump. We had no preference as to what brand was used, and it just really depended what was bought in by procurement for us. And the company had done some testing which had shown that all of the different brands of batteries and the different types of batteries have slightly different measurements, and you'll have noticed that yourself if you've used different brands of batteries within the pumps, and that some of the batteries fit really tightly and some of them are a bit looser, and there can be a difference of about 2 millimeters between the different brands of batteries that are used. So this was a very general warning at this point, and at that stage it was just a warning that medical physics should be checking the integrity of the battery housing whenever the pumps were in for routine service or were in for repair, just to make sure that it was in good condition. Next slide, please, Jackie. And then in 2019, there was an alert about fluid ingress oh, stick with us. Can you go back a slide, please? Of course. Yeah, that's the one. Yeah, sorry, that's the one.
Sorry, can I just interrupt a wee minute? Is there a dialogue box or something open over the slides? The slides are getting blanked out. With a box, with a black box.
Oh, right, hold on a wee second.
Sorry for interrupting.
Not at all, not at all. Is that better?
That's it, yep.
Right, okay, thanks, thank you. Okay, we're back hook with gas. So the following year was when we got the actual third letter about the battery housing, and this is when the company now actually recommended that we had.
You can see these slides.
But it's because I had the videos on that side. So
So
it's sorted.
So at this stage, it kind of moved up a gear, and the company now recommended that we had foam pads placed behind the connectors to improve the connectivity. And this was obviously something that would be done by medical physics when the pumps were in repairs. And just to give you an idea of where these sort of safety notices come from, they did this safety notice in the back of 13 cases in the UK of batteries losing connection. So that equates to about a 0.04% incident rate. So it wasn't something that was very common, but obviously just with the use of the pumps and how we use them and why we use them, it was deemed important enough to actually put that safety notice out with that tiny incidence rate. Next slide, please, Jackie. So the same year, we had a further field safety notice that were coming out thick and fast about the pumps at this point. And this was when the pumps were actually bought over, the company CME was bought over by the larger company BD. And they seem to have an uptake in some issues with the pumps that they've now taken over responsibility for. And this was when there was this specific warning about fluid ingress into the pumps. And we've always known that the pumps are susceptible to fluid ingress, so that's why they shouldn't be used in bathrooms when patients are taking baths and showers, because they're even sensitive to steam ingress, not just fluid ingress, but steam ingress. So this was a formal warning from the company about the potential damage from fluid ingress. So we already had the mechanisms in place to discourage or to try and discourage fluid ingress into the pumps. But no, we have had pumps that are drop down toilets that are covered in excrement from soma bags. So it does happen by accident sometimes, but there are the routine stuff that we can try and avoid. There was also a worrying notification from BD at this point that they just came out and said that we should no longer be using any pumps that were manufactured before 2012. And just to give you an idea, for our bunch of pumps that we have, the vast majority of our pumps were bought before 2012. They're version 1 and version 2 pumps, because we've been using them from about 2008. So this statement came as a bit of a shock out of nowhere, and we basically couldn't implement it because we couldn't withdraw all the pumps from use that we currently had. So unfortunately that was put on the back burner while we got some clarification about that, especially when you think about the date and the fact it was 2019 and it was pre-COVID. If we'd had to withdraw most of our stocks of pumps, it would have been absolutely catastrophic. Then later on that year again, we were now on to the third generation pumps being made by BD, and there were some areas that had bought these third generation pumps. We didn't have any at that point. We got some subsequently, but some areas had been using the third generation pumps from kind of 2018, 2019. And what had been found out kind of post-marketing was that when you use these pumps, because of the upgrade in the software, and lots of technical things that I don't really understand, the outcome of it was that basically one battery only lasted for 24 hours. And for our patient group, especially the ones in primary care, that was really impractical to ask people to change a battery every day, and obviously very wasteful as well. So at that point, we decided not to implement any third generation pumps, especially into primary care at that point, because of the battery issues. But BD were promising us a software update that was actually only implemented in we got it last year in 2021, and that's why we're now using the newer pumps. Next one, please, Jackie. Next slide, please. So one of the last notices to come out was this warning about the screw leads. So with repeated use, and you know what it's like with our pumps, especially, well, most of the T34 pumps actually, they are pretty much in constant use. You can imagine the ones in primary care especially there's very little pumps that sit about doing nothing, and most of the hospice pumps are really well used as well. So again, there's a general warning about inspecting this lead screw prior to use, and if you see something like that white debris on it, white plastic debris, that is an indication that the pump shouldn't be used and should be sent to physics for to be cleaned. They have the special equipment to be able to clean that lead screw. So we just have to do a visual inspection to make sure that that's not happened. and if it has, send it off to physics for repair. Next one, please, Jackie. And then in 2020, just before COVID hit, we had the recommendation from BD that we should only use the one type of battery with the pumps. So they were saying they could only recommend the Duracell Plus batteries for the pumps. And so we did implement that. That was quite tricky during that time because of when it happened. And we all duly went over to using the Duracell Plus batteries. They said it was they could guarantee the use of the pumps with the Duracell batteries in use. The difficulty about that was that the Duracell batteries were significantly more expensive than the ones we used to use, but we had to just absorb that extra cost for a period of time. And finally, last year, the company then said they could recommend the Panasonic battery that you can now order from PCOS as well for the pumps. Because it's not sensible just having one brand of battery to be used for the pumps, because what happens if that battery goes out of stock worldwide and you can't get hold of it? So it's certainly much better now that we've got the Panasonic one to pick from as well. So the Panasonic one's much cheaper, so we should be using that first line. And if you can't get the Panasonic, then obviously use the Duracell. That would be absolutely fine. Next slide, please. Thank you. We have a continued problem as well as since we switched over to the bronze syringes, which was probably, oh gosh, 2014, something like that. It was a long time ago. We did have quite a lot of reports of the syringes snapping at the lower end, and this was a particular problem with the 30ml syringes. Some sites reported it more than others. I've certainly had quite a few reports from primary care over the years, but there was certainly quite a few reports from a couple of the hospice sites, so much so that PPWH and Mar-Apr routinely use 20ml syringes now rather than 30ml syringes because of the issues with the snapping syringes. And it's because the 30ml syringe, the lower end of the 30ml syringe pokes out from the lockbox. And we have proven, and medical physics have proven, that the bronze syringes are not as tough as the BD ones were. So if the pump is dropped at all or gets a knock, there is the potential for the lower end to shear off. Broad are aware of this. There's nothing they can do about it, or nothing they're willing to do about it, because to fix it, they would need to completely change how they make their 30ml syringe, and that is quite a costly process for them to do that. They would need to change the mould, and they would need to change the manufacturing process, and they haven't done that as yet in the 8 years that we've been using them. I don't think they're going to do it. So just be aware of it. Please continue to report if it happens, because I haven't had any reports for a while. I'd certainly encourage district nurses to report it as well if it does happen. You can see the example there that actually happened with a 50ml syringe. That was before we had the 50ml lock boxes. So it does happen. Just be aware of it, be conscious of it, and if it happens, please let one of us know about it and report it in your normal fashion as well, so we can keep an eye on it and keep going back to Braun to see that there is a problem with it over the years. Next slide, please, Jonathan. So you'll all be aware that more recently, in the last year, we have had new pumps made available to us from BD. What's actually happened is that we got some extra stock of pumps from the COVID stockpile. There was a whole vast number of pumps that were purchased by Scottish Government as part of the COVID response, because we identified that we needed lots more pumps. There was lots of areas that were struggling with the amounts that they had available. What we couldn't do at the start was release them for use because of issues with the software, and the batteries only lasting for 24 hours. But that software has now been upgraded, and as a result of that, all 6 hospices now have the upgraded pumps for use. So you either have a brand new Bodyguard T pump, which basically looks like a T34 pump with just different livery on it, and different kind of branding, different key symbols on it, or you have an upgraded version 3 T34. So all 6 hospices have those in stock now, and I've been using them for quite a number of months. What's happened as well is that BD have given us 600 Bodyguard T pumps to replace all our version 1 and version 2 pumps. So I don't know why they've given us them, because that's a heck of a cost, but they've given us them. But what we're now waiting on is medical physics have to go through every single pump, and they have to commission it, and they have to program it with our specific program, and that takes about an hour a pump to do that. So medical physics are under extreme strain with their staffing as well, like everyone else. So we're gradually trying to get that stock available. So what will eventually happen is that all the old version 1 and version 2 pumps will be removed from use from Great locally to Glasgow and Clyde. So we'll be able to get rid of all of those pumps, old pumps from primary care and from the hospitals, and everyone will be on the version 3 or the Bodyguard T, the updated version 3 of the Bodyguard T pumps in the not too distant future. Well, we hope it's probably going to take us a while to do it. It'll probably be a matter of whenever a pump goes into medical physics for repair or servicing, they'll get a brand new pump out eventually, but we're not sure of the timescales yet. Medical physics are really struggling just now with their staffing as well. So that will happen eventually. So the version 2 pumps that you have in your hospices for discharges, eventually we'll be able to get rid of them and everybody will be using the same pump. So, and we will have a bit more extra pumps to go around as well, which will be good. There's certain hospitals that are very short of T34 pumps and always have been. Primary care are always looking for new pumps. They will always take extra pumps as well. So we should have a bit more stock to go around as well, which will be good. Next slide, please, Jackie. So this is just a wee reminder of the differences between the version 2 pump and the upgraded version 3 or Bodyguard T. You've got these visual charts in all the wards, or you should have. We've got posters of these just to remind you, but you'll be familiar with the newer pumps now. So the main differences are the keys are now universal symbols. There's no writing on them, and all of the pumps have a drainage hole at the back, which is to allow or to help with getting rid of any excess fluid that might get into the pump. And the battery life of these pumps is probably about 2 days. I think you probably agree you're getting about 2 days run out of a pump, of a new battery now, which is certainly a lot better than the 1 day we were getting with the first lot of version 3 pumps. Not as good as the older pumps, but certainly better than we had. Okay, I think that's it, Jackie. Oh, I just should say as well, one thing we're working on just now is there's a project going on about, one of the issues with the pumps is obviously trying to track the pumps. It's a constant issue for people trying to track down pumps when a patient goes somewhere else. So we're doing a pilot, or hopefully going to be doing a pilot about looking at tracking the pumps using QR codes. So there's an external company that's doing a project for us, and they've done some work already in Glasgow Royal with some of their non-palliative care pumps, lots of their other infusion pumps, and it's worked quite well. So we are hoping we'll be able to trial that for the T34s. So it'll be a matter of you scanning a QR code to log where a pump, either where a pump is or where it's going to. And there's a website that we would use to be able to track who the pumps are. So that has lots of good potential in it, and we will hopefully, possibly, probably be piloting that in Renfrewshire. Hopefully this year, and it would be an all sector pilot. So we need to track the pumps no matter where they were, whether they were in primary, secondary, or tertiary care. So that's quite exciting to see that come to light. That's got lots of potential. Okay. Number one, do the monoclonal antibody one.
Well, Jackie's just pulling up the next test.
Treatments for COVID.
Jackie's just pulling that up. Just going to pause just for 2 seconds and just checking in with the group. Does anybody have any questions for Elaine on that that particular presentation on the CME T34 pump update? Any questions?
There's a message in the chat box just asking to repeat about the syringe size.
Okay.
What about syringe size?
Is it Gary? Gary, yeah.
You were saying about using the 20 mil, and we're currently using the 30 mil in East Renfrewshire. Should we be using the 20 mil?
No, just two of the hospice sites made that decision kind of locally to switch to the 20 mil syringes. So that's just an internal decision they made because they were having lots of the snapped 30 mil syringes. So I wouldn't say no, don't switch if you're not having any issues, but just be aware if it does happen, that'll be why. It's because it's a 30 mil syringe that's in it. Okay.
If we do move on to the 20 mil, what's the kind of recommended total volume in the syringe?
19 mils you can put in a 20 mil syringe, so it's almost full.
Right, okay, that's great, thank you.
Thanks, Gary. Thank you for that question. Okay, so Elaine's now moving on to presentation number 2.
Okay, so this again, this is a bit of a random one, but we thought you might be interested to hear about the treatments that are available now for COVID, with regards to monoclonal antibodies and the oral antivirals. It's a very fast changing topic. Since Carolyn did the first 2 presentations earlier this year, the advice has actually changed, so we've had to update the presentation. But just to make you aware of what is available, because these treatments are potentially available for your patients at home, for yourself and your family members, and for hospice patients as well. So just to make sure you've got a general awareness of what is potentially available. So yeah, we thought just that, obviously not, this isn't really palliative care, but we thought it would be of interest to share what the current guidance is around these agents, in case because we have had patients in the hospices that have received them. There will be more patients that are potentially eligible, and there will certainly be patients who are eligible at home, and also just real information as well for yourself or for your family. So we've got a couple of different options we can pick from now, and so it's amazing how much the treatment for COVID-19 has progressed over the last 2 years. And there is the option of either a monoclonal antibody or an antiviral to be used for patients, and this is predominantly in non-hospitalised patients with COVID-19. The NMABs, which are the neutralising monoclonal antibodies, they bind to specific sites in the spike protein of the SARS-CoV-2 virus, and they block its entry into cells, and they inhibit its replication in that way. Whereas antivirals inhibit the development and replication of viruses in general, such as SARS-CoV-2. So since the last medicines management days, there's actually been some changes in what the recommended treatments are. Next slide, please, Jackie. So the options really depend on whether the patient is at home or hospital. So for the hospice, they're generally considered as hospital onset patients or hospitalised patients. But there's always the need to have the conversation with the patient as to whether they would actually want any treatment depending on the stage of their illness. But say there have been quite a few hospice patients that have received one of these agents, and certainly this year with the wave that we've encountered with COVID. The approaches are fairly similar in that the main first line drug is an oral drug called Paxlovid, but there are significant drug interactions known with that drug. So that might be an exclusion criteria for those patients to get Paxlovid. What there is now as well is there is a fantastic COVID-19 drug interaction website checker. So we can actually check, and that's constantly being updated, so we can check for any interactions for medicines that we haven't used for patients with these drugs yet. Next slide, please, Jack. So I'm getting mixed up here. So for non-hospitalised patients, the criteria is that they obviously have to have either had a positive PCR or it can be a positive LFT result. They should have symptoms, so it's not generally given to patients who have no symptoms. They should have some symptoms, and there's no evidence that they're getting better by themselves. And certainly for the patients who are clinically vulnerable, and that's the sort of patients who, most cancer patients will be clinically vulnerable, the hematological malignancies as well. If anybody's got any kind of immunosuppressant conditions such as HIV or AIDS, or any transplant recipients, anyone with a neurological condition such as MS or MND, or any kind of renal or liver disease as well, would be classed as clinically vulnerable. And they would be considered for Paxlovid first line, which is, as I say, is an oral treatment. Some of the inclusions include very severe liver disease, and certainly if you have an EGFR of less than 30, some of the treatments are excluded as well. Certainly you won't get Paxlovid, and there are certain significant drug interactions that we have to take cognizance of, and pregnancy and breastfeeding are current exclusions as well. If oral Paxlovid isn't suitable, then we can consider one of the IV treatments with one of the NMABs, and certainly it's been sotrovimab that we've seen administered to some of our hospice patients in the recent months. Patients at home who have COVID at home can also get IV sotrovimab. These drugs are so hard to say. And there is a site, I think it's at West Glasgow ECH, where patients who are being treated at home who aren't in hospital can go for the day and get their one-off infusion of that IV therapy if they need it. I know somebody who has MS and got that treatment, just the one-off dose. So that's a suitable treatment for them, because Paxlovid isn't suitable. Okay, next one, thank you. So for hospital onset COVID-19, can you get the next slide, please? Oh, I looked at the wrong one. Yep, so for Paxlovid, The license for it was granted on the back of this trial, which was a European trial, and it showed that there was a relative risk reduction of nearly 90% of hospitalisation or death with the use of this agent. So you can see why they were so keen to start using it. The evidence for the use of it did come from trials that were done in the earlier days, and that was when we didn't have so many vaccinated patients. So there are trials that are ongoing as well, looking at the use of it in our more vaccinated population now as well. Next slide, please, Jackie. So for the prescribing of it, Paxlovid is actually a combination product. It's two antivirals, nortractolivir and ritonavir. So it's a combination product, and you take it orally twice daily just for 5 days. There is serious risk of adverse effects, which I'll show you in the later slides, some of the most important ones that we need to be thinking of, and some of the most common drugs that patient might be on. If a patient has an EGFR greater than 60, then they can get the full dose. If their EGFR is between 30 and 59, then they get a reduced dose. So they are not eligible for Paxlovid if their EGFR is less than 30 mils a minute. Next slide, please, Jackie. So sotrovimab is the IV treatment that might be used as well. So we say we can give it to non-hospitalised patients as a one-off infusion at a kind of day service centre, and it had trial results which showed a relative risk reduction in hospitalisation or death by 85%, which is quite impressive numbers when you see percentages that are up in the 80s and 70s, 80s, 90s%. So that's why they're used, because they work. Next slide, please. So if we need sotrovimab for an inpatient, we have to indent for it from pharmacy. It comes from clinical trials, so we would just write an indent for it with the patient's name and CAI, send it to our usual pharmacy department, and they will send it over to us. So a one-off IV infusion of 500 milligrams, it gets given over half an hour. It does have to be stored in the fridge if it's not being used, and there is an inline filter that comes with it, so you have to use the inline filter in the line when it's being administered intravenously. But it's just usually a one-off dose, which is pretty easy to give. Next slide, please, Jackie. Molnupiravir, there's something like Lord of the Rings, isn't it? So that can be used when sotrovimab is contraindicated, it's not possible. And again, it's another 5-day course we'll get of that, generally in non-hospitalised patients. And again, its trial results showed a relative risk reduction of only 30%, which is not as impressive as the other medicines. That's why it's not used first line. You can see it's why that's not the preferred one that's used. Next slide, please, Jackie. We also have a medicine called Mar-Apr, and it's for IPU use, and it's a combination product as well. It's a neutralising monoclonal antibody, got equal amounts of each component in it, and it blocks attachment on the virus to the cell receptor. What it does have though is it's not as effective as against Omicron, so it's not being used just now. And this was really the change that happened over the course of the start of this year. Because it's not as effective against Omicron, the other agents have surpassed its use. But Mar-Apr is the only one that can be repeated if the patient deteriorates. The other IV treatments are a one-off dose, but Mar-Apr could potentially be repeated. Next slide, please, Jackie. So this is the very complicated flow chart for prescribing of it, just for your reference. But just of note in that is that some of the common severe interactions with Paxlovid are listed in the box on the left-hand side. So drugs like amiodarone is not super common. Apixaban is one of the drugs listed in it, is very common nowadays, so that's one to note. Diazepam, not uncommon. Domperidone, and some of the other less common drugs such as rifampicin and tadalafil. So it's really the common ones that we're worried about. And if a patient's in primary care, so if you've got any patients in primary care, they call the appropriate number, they get triaged. I think they speak to an ANP initially. They then speak to, it's all done by pharmacist prescribers in primary care, GPs aren't involved at all. So the pharmacist prescriber will do the consult over the phone and check for drug interactions, check the renal function, that sort of thing. If a script is appropriate, they will produce it electronically. It goes to, there's 14, I think, community pharmacies that keep Paxlovid. It's not kept everywhere. So the prescription gets sent to one of the pharmacies that hold Paxlovid, gets dispensed, and then it gets delivered out to the patient the same day. So it's a pretty sleek system that's in place now. and they've been very busy over the last 2 months. I must try and get some information on how many scripts they've actually issued. It's, you know, it's a 7-day service. It's done by volunteers, really, have to be honest. And I think, you know, some days they're maybe doing 10, 20 patients a day, across the whole health board, which is spread out obviously, but it's a fantastic service. So bear it in mind if you have anybody at home and they're potentially eligible for one of these treatments. I certainly will be thinking of it if I get COVID. So bear it in mind, and it is available, and bear it in mind for your inpatients as well. Okay, that's our whistle stop tour of that. Checking everyone.
Thanks very much for that, Elaine. That is so interesting, actually. And like you say, for the vulnerable people that we know, either professionally or personally, that's really, really good information to know, because I hadn't really heard that amount of detail on it. So thank you for sharing that. Just coming to the group, anybody quickly, any questions that they want to ask Elaine over that? Anything just needing further clarity?
Okay, so the next whistle stop tour is of a less commonly used medicine, but one we've actually had, certainly in one of my hospices, we've had a couple of patients recently who have been admitted on it. So it's just, again, it's just for general awareness, and because it is a less common medicine, there are some very specific cautions with it, and it's different how we order it and how we get hold of it. So it's important you recognise the name if you come across it, so you know how to get hold of it and how to manage it, etc. So the drug is clozapine, and it's an antipsychotic medicine which is licensed for schizophrenia in patients who are non-responsive or intolerant to other medicines. And it's also used in psychosis and Parkinson's disease when other treatments have failed. I have to say, I've never seen it personally used for psychosis and Parkinson's. It seems it's much more commonly used for the unresponsive schizophrenics. So it's not used lightly. It's not a medicine that is prescribed frequently, and it tends to be used when other things have failed. So it's a kind of last line effort to try and get the patient's symptoms under control. It is only available orally. So we have tablets, we have oral dispersible tablets, and there's also an oral suspension that's available as well. Next slide, please, Jackie. Because of how potentially dangerous the drug is, in some conditions, it is restricted to prescribing by a psychiatrist only, and it's only ever supplied by a mental health pharmacy department. So you cannot indent for this from your usual pharmacy department. If you send an indent for it, it'll be rejected or it'll be sent back. We have to order it via Leverdale Hospital Pharmacy. So they control all of the patients in certainly in Glasgow who are on clozapine. I must check for Clyde actually. I wonder if that comes through Dyke Bar. I must double check that. I don't know off the top of my head. One of the issues with clozapine is its potential for some very serious side effects. So it can cause agranulocytosis, which is very serious, and blood results have to be monitored because of that. It can also cause seizures, it can cause aspiration pneumonia, and it can cause a very severe constipation. And the constipation can be so bad that it can actually result in bowel obstruction. So it's a real concern with clozapine therapy that the patient's bowels are moving properly, but we are also obsessed with that anyway. That will be managed perfectly well by palliative care units. So, but agranulocytosis is probably the most important one to look out for. There's actually a UK-wide monitoring system which each patient has to be registered with, and that is to ensure that the bloods are taken regularly enough, and somebody's actually checking the blood results as well. The patient's white cell count with a differential count must be monitored, and it's usually at least weekly for the first 18 weeks of treatment. Then it goes to 2 weekly, up to a year, and then after a year of treatment, if the blood counts are stable, patients should be monitored at least at 4-week intervals. So it's a very regular check the patients have to get when they're on that medicine. Next slide, please, Jackie. So when it comes to double checking or doing our meds rec for clozapine, it's a wee bit more difficult because it's not a medicine that's prescribed by the GP, but it should be on the emergency care summary. It should be entered on the emergency care summary by the GP, and there should be a note with the dose, but the GP would note that they do not supply it and they don't dispense it. There is a clozapine alert within the mental health summary and clinical portal. So you can access the information there. We can also obviously confirm it with the patient or their carer and known medicines that they'll have. We wouldn't be able to phone a community pharmacy to check because it's all supplied from Levendale. We could, or from the psychiatry, the mental health pharmacy department, we could phone them for clarification as well, absolutely, or the patient's community mental health team. So it's important that it's listed in these sources so that wherever the patient goes, wherever the patient's admitted to, the staff there are aware that the patient is on clozapine, because what you don't want to do is miss any doses with it. It's very important that its administration is maintained. What we would normally do is we'd normally use the patient's own supply, and you have to use that. And if we need a further supply, you have to contact the mental health pharmacy department to get a new supply, and they organise all the prescriptions because it's done through a psychiatrist, and they will get the supply out to you. They usually send it out to us by taxi or courier whenever we need it, whenever we need a new supply. Next slide, please, Jackie. So for Levendale, the pharmacy number is listed there for you, so to check a bit in the Clyde area. I think it's probably Dyke Bar. They will also send a special kit for bloods when it's to be taken, and the bloods get sent away. The bloods aren't analysed locally; they have to be sent away to get done and to be recorded on the UK-wide monitoring system. They are also available out of hours as well, so that's the Levendale switchboard number for any out of hours calls you might have. So they're very good at keeping the medicine supply up with the patient wherever they are, and they will also supply it for discharge as well. So if a patient is being discharged from the hospice and they're on clozapine, it's the mental health pharmacy which will provide it for the patient to take home. Next slide, please, Jackie. So just some practice points to consider when it comes to clozapine. So we need to think about the reasons for admission, and we certainly need to try and exclude any potential clozapine side effects, especially constipation. That is very important to try and avoid that at all costs. You need to think about when the patient lasted the clozapine dose. So trying to make sure we don't miss any doses at all. It's one that you want to wake up patients for. Don't let them sleep through it. They need to make sure they get all doses every day. There is a really good website called MyPsych, which has information available on clozapine and its interactions and side effects, etc. They also have a really good mobile app as well. And one of the things we have to consider is if it's been more than 48 hours since the patient last took a dose, you have to titrate the treatment. You wouldn't just start at the same dose that the patient was on, and it usually restarts initially from a dose of about 12.5 milligrams. This would always be done in consultation with the patient's psychiatrist. We wouldn't be making decisions like that, but just be aware that if the patient misses any doses, we need to get advice, and we need to make sure we're retitrating it in an appropriate way. What we also have to consider with clozapine as well is, because we only have the oral route available, we need to think about what we're going to do when the patient loses their swallow at end of life, and we have had that situation quite recently, certainly in one of the hospices. You can use the other antipsychotics that we'll use. The main one that seems to be most similar to clozapine is olanzapine, which is not a drug that we use very routinely within our normal palliative care patients. It is available as an injection. It's an unlicensed injection, so it's a bit more tricky to get hold of, but we have used olanzapine injections subcutaneously for patients who have no longer been able to swallow their clozapine at end of life. But we would always try and have psych involvement when we get to that kind of stage, just to make sure we are treating everything we need to treat. These patients are usually quite complicated. They're not on clozapine for no reason, so it's important to have their input up to when the patient passes away. So it's an important drug to remember, but you won't see it very commonly, but just remember it is different, and we have to try and get some advice and information about how we carry on giving it to the patient. Thank you. I think that's that. I think that's last slide for that one. So,
Fiona, I'm just wondering whether we're probably going to run out of time for breakout rooms, because we've only got 15 minutes.
Yeah.
So it might be as well just, Elaine, are you okay if we just do it as a big group?
That's fine.
Okay.
I just think it might be too tight if we did it.
Excuse me. Okay, so the last one is just a quick, not really round up about the policy itself, the symptomatic relief policy. So this policy is currently used in 4 out of the 6 hospices. So if you're in St Margaret's, this doesn't apply to you. You can go and have a cup of coffee because you don't use the SRP. PPWH, we're going to be implementing it hopefully in the next month. So it is applicable to you, and it's already used in the other 4 sites. So it is for inpatient use, and it's good that we've got a joint policy across as many hospices as we can, because it makes it easier when it comes to reviewing it and updating it. So the important thing to remember with the SRP is you need to be familiar with what medicines are included. You need to be familiar with any exclusions and any exemptions they should be listed on the back of the Cardex when the prescriber signs off for use of the SRP. So you need to be familiar with the general principles of it. So before administering from the SRP, the prescriber needs to have signed the back of the Cardex to allow you to be able to use the policy in practice. Okay, and that's for every patient. So every Cardex needs to have that signed off. So it's the list of medicines, and these are all medicines which are either general sales list medicines or the pharmacy medicines. We're not allowed to have any prescription only medicines in an SRP, and we have to use the 2 other categories instead. So you're fairly limited with what you're allowed to include, but despite that, our SRP has quite a lot of medicines in it, so it covers quite a lot of scenarios, which is great. So, if you want to move on to the next slide, actually, Jackie, that's fine. So we've got some dummy Cardexes, which have obviously got some issues on them, and these are kind of practice issues that Carolyn identified with use of the SRP over the last year or so. So there's obviously a reason why we're asking you if there is something going on with the prescribing of it that we want you to have a think about. So is there any comments about this SRP on this Cardex? Will we just go with hands up if anyone wants to? You can't really see people, can it? It's a trouble.
Helen? I think Helen's got a hand up.
Susan, can you just facilitate that chat discussion around that, because we won't see
Yeah,
just through the
that's fine.
issues we're having. Is that okay?
That's fine. I think Helen, maybe if you just unmute Helen. Can you find the wee button to unmute?
Oh yeah, is that okay?
That's brilliant. Yeah, that's great. Thanks.
Just during Stilagel is topical.
Okay, so then Stilagel's topical.
Yeah,
And
that's fine though.
yep, and Jackie and Jane, I think you guys have put your hands up as well.
Yeah, it says that the saline nebs are topical, and obviously they're not.
Okay, thank you. Anybody else got any comments?
No, it's not saline nebs. It's saline. What's she in there? It's 100 mils though. It's a bladder. That's a bladder one, I think. Hold on. Yeah, it's not nebules. That's the sodium chloride catheter patency solution, which is 100 mils. I think she's meant there. And that is, yeah, I don't think it's nebs because it's 100 mils, isn't it? So the issue with this one in particular was that the SRP is dated from the 23rd of January, and Stilagel was actually administered on the 22nd. So the Stilagel has been administered before the SRP was actually activated, which shouldn't really happen, and nobody's going to take a registration for that. But just be aware, if you want to use the SRP, it needs to have been activated by a prescriber, and it can be any prescriber. So just be aware of that dates if there's any auditing that's carried out. Okay, next slide, please, Jackie. So we've got this wee scenario here. So we have patient who's prescribed glycerin and bisocodal suppositories. They're prescribed in a bowel regime, so again, Monday, Wednesday, and Friday. The patient requests an additional suppository from you on a Sunday. Can you administer it from the SRP. So the exemption there that's been highlighted in that cardex is just for paracetamol, so everything else the prescriber thinks has been fine. So there's no exemption for it, but what's your thoughts?
Over to you, Susan, and the team.
Erin, do you get any thoughts? Fraser?
I was just thinking, would the prescriber put an exception if they didn't want them to have extra suppositories, like already on bill regime? If they didn't want to have any extras?
Yeah, so this is one of the scenarios where it's not 100%, it's not black and white, because the prescriber hasn't excluded the glycerin and bisocondyl suppositories. It may be that that's an error, and that's not been done. That's not been a conscious decision not to exclude them. It's just that they've been started on it regularly, and somebody hasn't thought, oh well, they could potentially get that from the SRP as well, so I need to exclude it. So they could potentially get another 2 doses of the suppositories on this by way of the SRP, but I think when somebody's on a regular bowel regime, I would probably clarify with medical staff first if that's okay for them to get extra, because you have them on a regular bowel regime, and that should be, you want to know how much they're going to need regularly. So giving some extra is going to muck that up a little bit, isn't it? So it's one of these scenarios where it's not clear cut, and it could just be an error that the prescriber's not excluded the glycerin and bisocondyl suppositories, especially if they've been started regularly after the SRP is being activated. So I would probably get clarification on that personally before administering it.
The last time, at the last one, this is the one that caused quite a bit of discussion amongst the group.
Yeah.
Because exactly what you've said, Elaine, it's not black and white, and it's almost as if having the SRP kind of muddied the waters a wee bit there. So there was quite a wee bit of discussion round about that. But
what did most people say, Susan? Did most people say they would give it, or did most people say they would?
It was probably Fraser's point came up with some of them. Some people said they would give it. Some people felt that they would go for medical advice. And then it was kind of went back to the prescribing. Should it have been down as an exclusion? But no, just I think it just highlighted that it was just because you've got an SRP doesn't mean to say that all decisions are black and white. You know, there has to be a bit of discussion and things round about it.
Yeah, absolutely.
Yeah.
It's always important as well to for prescribers to look and see what's been given as part of an SRP.
Yes.
And maybe that's something certainly it's important you review and see what has been used. Every time you're looking at a cardex would be the ideal time to do it, because there is the potential for things to be given repeatedly and it perhaps not being picked up. Okay, that's fine. We'll go on to the next one. So I'll give you a wee minute or two just to have a look at this. So couple of different things being given in the SRP. There's just one exemption there. Any comments on what's been given?
Fraser, you get your hand up.
It was just, since the peptac's been given 3 times, does that not mean it gets prescribed regularly from then on, or onto the PRNs?
Yeah, so just to make sure you're aware of what the maximums are you're allowed to give through the SRP. So you come to the maximum per peptac, so the maximum 4 doses is allowed. So okay. So one, certainly you can only get 1 more in the SRP, so it's certainly time to think about getting that prescribed in the PRN part of the cardex or regularly.
Thanks. Anybody else get any comments? Ellen?
They're saying that it's been given twice, so should only really be given once and then be prescribed.
That's right, Ellen. So it's got a very tight restriction of just been allowed to be given one. So yeah, that second dose shouldn't have been given without it being prescribed on the main body of the Cardex. Thank you. So just be aware of that, what the maximum doses are that you're allowed to give for each agent. It does vary a bit from 1 dose to, I think the maximum is probably 4 doses of some things. Thanks, Jackie. Next slide, please. So for this one, we have a patient who told their weight is 62 kilograms and the prescribed PRN paracetamol on the PRN section. The patient's requesting a dose of 1 gram rather than 500 milligrams. Could you administer the additional 500 milligrams from the SRP?
Any volunteers for this one? I think this one caused a bit of discussion as well.
Yeah.
So it's not straightforward.
It's not straightforward, no. And again, this is where kind of clinical judgment comes into play as well, doesn't it? Because the patient's weight is okay to get a gram dose of paracetamol, but they have deliberately been prescribed 500 milligrams as required. So there must be a reason why they've been prescribed 500 milligrams. I think that would be a deliberate decision. So there may be something else that's coming into play there, maybe to do with their liver function. So what do people think? Would you give it?
There's some people shaking heads.
Some people shaking heads.
Some people shaking heads. Anybody want to comment? Anybody want to say anything?
You would need to know the clinical picture, I think. And
that's why it is a clinical judgment, isn't it?
yeah,
It is definitely a mission that the prescriber hasn't excluded paracetamol on the SR. So
Thanks, Helen.
it should.
Sorry.
Sorry.
No, I think Jackie and Jane have got their hands up as well. I just wondered if they wanted to come in with something.
It was really just to say the same thing, that if the prescriber's intentionally done 500, I would look at their LFTs and things like that in their clinical picture before. But yeah, it should have been excluded from the
So that's something to point out to which
Thanks, Jane.
in next. Yeah, thank you.
Thanks, Jane. And there's also a comment in the chat from Eileen to say that she wouldn't, not until she'd clarified why only 500 milligrams prescribed. So thanks for that, Eileen.
Thank you.
Well,
we're on time.
Well,
I'm bang on
I don't know
time.
how that happens. Sometimes theirs is not to question why. But I just, you know, despite all the ITs, we'll try and get the IT sorted at this end and knock off that other screen that is causing us a major headache. But just to thank Elaine, honestly, for such a lot of information to offer out to us across all of the hospices. It shows why these days are just so important. But some of the things I heard just from the T34, the CME T34 update was, you know, the practical issues that are associated with the pumps, but ways around that. You're talking about the syringes and the batteries and how we've moved on, all of the alerts that have been sent out over pre-pandemic and then during the pandemic and beyond. And actually the fact that the gifting from the Scottish Government of 600 pumps or purchasing those pumps is just phenomenal. Purchasing the pumps during the pandemic and then the company offering us these 600 pumps, just
So we stay with them, I think.
I can't really get my head around that one, but again, I'm not going to question why we've been offered all these pumps, so that's great. And the monoclonal antibiotics, as I said, I knew very little of that personally, but I think to know that, I think it's really excellent news that actually the outcomes are so positive from these particular drugs. What a great service, the 7-day service that they're providing. It seems so well organised and structured, and that's really great to hear. I think from a professional and a personal point of view, Elaine, as you said, the clonazepam, very rare, but really important that you know about it in case somebody should be on it, but really important that we know about it from the side effect profile. So that we can, you know, making sure that we are picking up on these things, especially as you said, things like constipation and the major issue that can cause. And moving lastly, on the symptom relief policy, I think what a great support that is for the hospices to all be having that, and in terms of consistency, but also in terms of when it's coming to renew policies, but getting feedback from all the hospices that use it so that we can alert to things that are not quite right. So I think you've given everybody real food for thought, and I want to thank you in that, because that was a whistle stop down.
Going for a coffee there.
Probably a GT, she's lying. So thank you very much, Elaine, for that. Again, really, really helpful. And as you know, Elaine and the other pharmacists are a great resource to us all, and always happy to take any questions or respond to any difficulties that the teams are having. So we're very fortunate to have them. So thanks very much for that, Elaine.
Thanks everyone, thanks for your input. See you
Thanks, Elaine.
All right, thank you.
Hope there's no more.
So I will just introduce myself a wee bit. I'm Debbie Morris. I'm a GP by trade, although over the last couple of years I'm really full-time doing diabetes, mostly clinics and a little bit of inpatients at the Queen Elizabeth, and supporting the community nurses with with their caseload. I do still do GP, but it's mostly out of hours, mostly house visits actually. So I do palliative care in that part of my job. I've got no conflict of interest at all to declare. Everything is what I think. So let me just. I thought I would talk a little bit about a blood test that you might not be familiar with, but we're increasingly using in diabetes, so you'll start to see it in people's notes. A bit of back to basics about types of diabetes, because it's actually changing a little bit just now, touching on just new technology and pumps and things like that, which I suspect you've probably not seen much of, but as we have an older population with pumps, it will probably be something that will start to come on your radar. Most of it is about just the medications and sick day rules, a little bit about monitoring and targets, and then I've just sort of come up with some cases that I've come across before, but like I say, happy to discuss cases or queries or questions at the end. Couple of sources of information. The Diabetes UK document, I suspect you're familiar with. It's been updated in November last year. It used to be a blue front cover, so you might be more familiar with that version of it. But it was needing updated because the information about SGLT2s in particular had changed, and that's very good. And it really does follow where GGC have their own guidelines, and what we do in practice. It is a very practical guideline that does work in practice. The other document you might not be familiar with, and I'll send PDFs of these to Kay, is a document that was actually developed for junior doctors on the wards for prescribing around diabetes, but actually it probably has quite a lot of transferable information about managing hyperglycemia, steroid-induced diabetes, and it's very practical and easy to adapt for a palliative care scenario. So the C-peptide blood test is a marker of insulin production from the pancreas. So it has been around for a long time, but it used to be a very difficult test to do. So it was only done in very specific situations, but it's now a blood test that can be done at the Fleb hub like any other blood test. And when the pancreas releases insulin, it also releases a C-peptide. Insulin is difficult to measure, but the C-peptide is much easier. So we can use it to establish how much function is left in a pancreas at that point in time. You would need a paired glucose with it to interpret it, because if the blood glucose is low, the C-peptide will be low, but that's just because it's not been stimulated. And it's particularly useful after 3 years of diagnosis. And actually, we are now, or we will be doing a C-peptide on everyone with a clinician diagnosis of type 1 diabetes, because a big study in Edinburgh showed that the misdiagnosis rate was quite high, and I think it was about 14% of people that were labelled as type 1 had residual pancreatic function, and some of those people came off insulin. If the C-peptide is high, so there's lots of insulin production, that would fit with a diagnosis of type 2 diabetes. If it's low or absent, there's various scenarios that can be going on, but it just tells you at that point in time there wasn't much secretion of insulin from the pancreas. So we use it now. Most people, new diagnoses will be getting a C-peptide, and we are increasingly doing it on people who've had longer term diagnoses. So just a little bit of background about diabetes, revision for most of us. So in type 1 diabetes, the pancreas doesn't make insulin, so the antibodies have destroyed it. So the C-peptide will be low or absent. So the patient needs insulin, and without insulin, then a complication, diabetic ketoacidosis can develop, and that can develop within hours. A reminder, type 1 diabetes can develop in later life. You can develop it in your 80s or 90s, and it just develops slower. It's not such a florid onset as in younger people. And a new thing for us is immune checkpoint inhibitor induced type 1. So immune checkpoint inhibitors are being used by the oncologists, and they can sometimes cause a very florid type 1 picture where people can become unwell over the course of a week and go into TKA. And those patients are referred to as having type 1 rather than secondary diabetes like they would be if they were steroid induced. And just the difference with type 2 diabetes, pancreas either doesn't make enough insulin or it's making plenty of insulin, but the body's resistant to it. And people will have a high C-peptide. So not just a normal C-peptide, but actively a high one because their pancreas is pumping out insulin, but their body can't respond to it. Typically overweight, but not always. Some disease processes can make you a bit resistant. And then you might hear the term burnt out type 2, and that's where the pancreas starts to work less well over time. So people who are on insulin with type 2 diabetes, it might just be because they just need more insulin because their body's so resistant to it, and they will often be on very high doses. However, if somebody's had diabetes for 20 years, they can become quite dependent on insulin. And although they don't have type 1, they may need insulin to stay well. Secondary diabetes, some people would class that under type 2. In Glasgow, we're quite proactive at coding it as secondary diabetes. Usually, so it's either drug-induced, typically steroids, or we see it with tacrolimus. Or there's been an insult to the pancreas, so pancreatitis, surgery, cancer, and those patients will often have a reduced C-peptide. And I think it's useful to be mindful of people who've got secondary diabetes because they can become unwell the same way as somebody with type 1 diabetes can. If their pancreas is completely destroyed through surgery or pancreatitis, then they can go into DKA just the same as somebody with type 1. And monogenic diabetes is rare, but it's increasingly being diagnosed, and it's one of the reasons that people with type 1 are having their C-peptide checked, and it's often managed with glycoside, or they sometimes need insulin. And the one I don't have here is gestational diabetes, where people are very resistant during a pregnancy. So just a wee bit of information about glucose monitoring, because again, this is a relatively new thing over the last few years. So there's various ways and devices for doing this. So we've got continuous glucose monitoring, which would be things like Dexcom and flash glucose monitoring, and that's a Libra, which I suspect you're a wee bit familiar with and that you'll have had patients in the IPU. And this measures the glucose in the interstitial fluid, so it's not the same as a capillary blood glucose, but it can be close enough. And now with Libra 2, there's hypo alarms, and obviously for patients, the absence of finger prick testing and an idea of what's happening overnight is incredibly useful. Cons is it's not accurate for everyone. And that's a picture of the Libra down there. It's a small device that usually goes in the arm. And this is an example of what patients would see if they scanned with their phone. So it gives you what the blood sugar is then and the last 8 hours. And it's something, I don't know if it's something that you've used in the IPU. I think if there was a scenario where somebody had erratic blood sugars, didn't have a Libra, if you spoke to the diabetes nurses, they would probably be able to find one. The reps sometimes leave one, and one would be able to be sourced if there was a particular scenario where it would be helpful. or if patients have it at home already, they could bring it in. I'm just going to very briefly touch on insulin pumps, because I suspect that's not something you've seen much of. However, we now have patients that have had pumps for 20 years and they're developing other medical conditions or cognitive impairment, and that's new for us as a team, how we manage that. Pumps work by providing a constant supply of a rapid-acting insulin. So the rapid-acting insulin is what gives them their basal insulin, but it's just at a very low level. And then before they eat, patients will bolus what they think is the correct amount. So it means if it's dislodged or there's a problem with it, there's only 4 hours of insulin in their body, and it's a real risk for diabetic ketoacidosis. So traditionally, pumps are only really suitable for people who are, very engaged with the service, and the risk of that is not, they don't have chaotic lifestyles. But of course, 20 years later, some people are not so careful, and it's something that we're having to be more mindful of, making plans for coming off pumps. You would be liaising with the pump team with a view to switching to subcut, hopefully before any sort of crisis came that a patient ended up coming into the IPU still on their pump. I wanted to put this in because there was a clinical incident recently where a gentleman was having hypos, and the ambulance crew didn't realise that their device was a pump that was delivering insulin. They thought it was a continuous glucose monitor. And so they were trying to treat the hypo, but meanwhile, there was an insulin pump that was merrily infusing insulin. So one of these is an insulin pump, and one of them is a CGM as a monitor. So if you do have somebody, then just make sure that it is what you think it is. So this is a Dexcom. This is monitoring blood sugar. This has 3 mils of insulin in it, and it's actually that there's no tether, there's no there's no tube to the pump device like there is for some of the tethered pumps. So that's called a patch pump. So I just thought that was just worth a wee reminder about. So HbA1c targets and monitoring. So in palliative care, we're not really fussed about HbA1c targets. We're more interested in the blood glucose, and really just for the avoidance of symptoms. So you want to avoid less than 6 because there's a risk of hypo. Really, less than 3.5, 3.2 is sort of dangerous for the brain, but if somebody is used to running at 10, 15, they might start to get hypo symptoms at 5 or 6, but it's not dangerous to them, it's just unpleasant for them. You want to avoid blood glucose above 15 because of osmotic symptoms, and particularly if people are elderly or they can't get their own water, people can become quite dehydrated if they're losing a lot of water into their urine. And the chart here would, we often say, HbA1c is between 65 and 80 for frail and elderly, and that this table just gives an indication. We're really seeing, blood sugars between 9 and 12. And 8 and 12 for fasting targets for elderly and frail patients, and 6 to 15 for those at end of life. I suspect that's familiar with you. So just a wee bit about monitoring blood sugar. So routinely in people with type 2 in the community, blood sugar strips are only really prescribed if they're on hypo-inducing medications. So that is gliclazide and insulin. And broadly speaking, we'd be asking people to check their blood sugar before you administer anything to yourself that might give you a hypo. And then you would ask people to increase the frequency during illness if somebody's had recent hypos or are prone to hypos, or temporarily to guide treatment decisions. And really, fasting blood sugars are much more relevant. So if somebody's blood sugar goes up after they eat, it doesn't really matter. If it comes back down, that's fine. So usually if we were saying 4 times a day, before breakfast, before lunch, before dinner, and then at bedtime. And consider less frequent regimes if stable. If their HbA1c is elevated and there's no real risk of hypo, or if they're end of life. And you might want to do, depending on the regime, if you just do every second morning, they might be going higher later in the day. So maybe, twice a day, just once or twice a week might be more suitable, depending on what the regime is. If somebody's just on metformin and SGLT2, like or a Flozin, GLP, which is the weekly injections, a gliptin or a pio, there's no real risk of hypo, so they often won't be checking blood sugars in the community. But you would want to probably do that in the IPU to establish their current level of control, and as part of an IPU protocol. And I'll be interested actually to know what the protocol is for checking blood glucoses in people who are not on hypo causing medications. In people who have type 1 diabetes or pancreatic diabetes, where we're thinking they're reliant on insulin, they'll usually be on 2 to 5 injections a day. And again, they will usually be injecting checking before each injection. And again, you would be considering less frequent regimes if they're stable. And just a wee reminder about the Libra for type 1s. If they're not on it already and you think it would be useful, then get in touch with the Diabetes Hub. Just a little bit about checking blood sugars when steroids are being started. So this is a guideline from that junior doctor's FAQ document. So steroid-induced diabetes, so that's when you get high blood sugars caused by steroids in people without a diagnosis of diabetes, and then you get steroid-induced hyperglycemia, which is a worsening of control. So in the wards, if somebody started on steroids, if they don't have diabetes, they are supposed to have a once a day blood glucose check, usually in the afternoon before the evening meal, because typically, particularly with prednisolone or Dex in the morning, it's usually about 4 o'clock that peak effect will be. So you're trying to catch a rise during the day, and because of the way the steroids work, the effect of them is often worn off by the next morning. So if you're only checking a morning blood sugar, you won't pick up that they've actually been up at 18 at 4 in the afternoon, and then it's come back down. And then 4 times a day in patients with known diabetes, if their blood sugar is above 12 on more than 2 occasions from 24 hours of the start of steroids. So I'll just keep going. Medication. So again, a bit of a revision, but I think it's useful just to remind ourselves. Metformin is a safe medication. It restores the body's response to insulin, so it's an insulin sensitizer. So again, no risk of hypos if patients are on just metformin. Starts to work within 48 hours, but can take up to a week to get the effects for a given dose, and that obviously works the other way if you're stopping it. We always reduce the dose if the EGFR is less than 45 and stop it below 30. Oh, all right. Sick day rules, similar to ACE inhibitors, etc. Withhold and restart when eating and drinking normally. From a palliative care point of view, if somebody's stable, eating, drinking, not losing weight, and importantly, if it's not causing GI side effects, then you're probably as well to continue with it, particularly if the person's overweight, because their control will deteriorate. 3 months later, their HbA1c will be higher if it's stopped. Obviously, if people's appetite starts to go down, if they're not eating much, that's when metformin can start to cause side effects. So you may then, in that situation, want to be reducing it or stopping it. And depending on what their prognosis is and what you're expecting, if you think they might still be, out and about 3-6 months later, you probably need to put in a safety net of an HbA1c check 3 months after stopping it, just to make sure that things haven't gone awry. And yeah, so if they're eating less, so just appetite, weight loss, if you're thinking a sort of a weeks to months progress, then yes, of course, stopping it is definitely the thing to do. Gliclazide is a good medication in the IPU, and it's had a bit of bad press, I would say, over the last few years about concerns of causing hypos in the elderly. But just the third point there, it's only really a concern in a frail, elderly, unwell, or kidney disease if the blood glucose control is too tight. So we'll see high vet referrals for the Northeast, and I'll see GPs writing in, and somebody, an elderly lady has an HbA1c of 90 and they're on 80 BD of glycoside, and they don't want to increase the glycoside because they're concerned about the frailty or the negative effects. And the answer to that is increase the glycoside, because the HbA1c is 96. Hopefully it'll bring it down below 80, and that's all that you're looking for. It's only if the HbA1c is less than 65, then you would be, trying to think of, what else you might do. The way glycoside works, just to the top point, increases the secretion of insulin from the pancreas. So you need to have some pancreatic function for glycoside to work. It's a good medication in the IPU or in the wards because it sort of works the day that it's prescribed. So there's not really a hangover. If you've got a high blood sugar in front of you, you can use glycoside and it will usually bring the blood sugar down within a couple of hours. We try not to use it too early in type 2 diabetes because of the risk of hypo and weight gain, but that's not really a concern for yourselves. So it's a good option if somebody's got uncontrolled diabetes. Might be worth trying it for a couple of days to see if you can avoid insulin steroid induced, or you might have to use it temporarily if you're having to withhold other medications, and you just titrate it to blood sugars. And I've got a couple of cases later. SGLT2 inhibitors, I think, are probably maybe a bit less familiar with yourselves. So there's 3 that are on the formulary in Glasgow: empagliflozin, dapagliflozin and canagliflozin. And patients will refer to this as the sugary urine tablet. So if you ask them, are you on empagliflozin, and they'll say, oh, I don't know. And then you say, have you ever been told that the tablet puts the sugar in your pee? And they'll say, oh yes, I know that one. And the way the SGLT2s work is that normally your kidneys work quite hard to keep the glucose in the bloodstream. And obviously the blood glucose is above a certain threshold that is breached and glucose goes into the urine. But these tablets block that reabsorption, so the glucose goes freely into the urine, and people's blood sugars improve. There are some consequences of having sugary urine. So thrush is one of them, and that can be really unpleasant and problematic. And it is a reason we just stop it, even though it's working wonders for blood sugars. I would usually say to somebody, get the thrush treatment from your GP once or twice, but if you get it 3 times in quick succession, we just have to say it's not for you. Urinary frequency can be a problem. On average, the trials showed that people went to the toilet once more in a 24-hour period, but for some people, they start taking it, and that night they're up 5 times, and it's just incredibly unpleasant. And again, that might be a reason to stop it, and it's something we would counsel people on. And weight loss is a desirable side effect for us using it. People will pee around 200 to 300 calories into their urine each day with it. So that can be really useful. But if you've got somebody who's losing weight and you don't want them to be losing weight, then it's probably one of the medications to consider stopping. The other concern, if you like, with flozins is patients have to follow the sick day rules with it, as they should be with metformin and ACE inhibitors. And this is the GGC sick day rules that we would, or that I would give out to patients. So we'd tell them to stop it if they're unwell with diarrhea, vomiting, unable to eat and drink, stop it 2 days before major surgery, restart it when you're feeling better and eating and drinking normally. It's not something we advise if people are trying low calorie or keto diets. And you would obviously speak to your doctor or nurse if patients have got concerns. And the issue with it is a condition called euglycemic diabetic ketoacidosis. So this is similar to diabetic ketoacidosis in type 1, but the thing that confused everyone initially was that the blood sugars were often normal or less than 14, which is very unusual in a type 1 DKA. And it's because the SGLT2 is pumping the sugar out or letting it freely into the urine, and it masks the hyperglycemia. But in the same way, patients develop ketones, and then they're at risk of developing an acidosis. And you want to consider an acidosis if the patient's unwell. So it's not so much a problem if somebody's got ketones but they're well. But if they're unwell and they've got ketones, then that's when you have to start to think, actually, is there something else going on? And people with a ketoacidosis typically will have nausea, vomiting, malaise, anorexia, perceptions of breathlessness. I realise I'm reading out symptoms of people who are probably being admitted to the IPU all the time. Abdo pain, diarrhea, and ketones. So 2+ of ketones in the urine or 1.5 millimoles per litre in the blood is significant. Now, I suspect you don't have blood ketone measuring, any yes or no in the IPU. It's still the same Abbott machines. The biochemists can add a software update to it, and then you just need to get different strips. The strips are expensive, so and it may not be something that that you need, but with increasing prescribing of SGLT2 inhibitors, it might be something that you have to be more aware of going forward. So risk factors for developing this complication is if somebody's got low endogenous insulin, so maybe they've had a history of pancreatic problems, alcohol dependence, dehydration, reduced calorie intake, and if they're slim, suggesting that they might be low in insulin anyway. So to that end, when do urine ketones matter? So in type 1 diabetes, if blood sugar is persistently above 14 over 4 hours, then they are at risk of DKA. And if they've got ketones 2+ in their urine, you sort of have to, I would say, consider whether DKA is brewing. The benefit of blood ketone monitoring is that there's no lag, so patients can follow their own sick day rules, which is typically, so if somebody's got ketones and a high blood sugar, it's actually quite straightforward. We ask them to take 10% of their total daily dose. So all of their Levemir, all of their Mar-Apr, if that's normally 50 units, then we say take 10% of that as a single rapid acting bolus. Drink plenty of fluids and recheck your ketones 2 hours later. And it's incredibly effective. They might need to do it again a couple of times, but it's something that would potentially avoid transfers to the medical unit if you had somebody brewing a DKA, if you had the means to check a blood ketone, because if the ketones are 5 and they've taken a rapid acting bolus and they've managed to drink some fluids, or you've managed to get some fluids into them, and 2 hours later their ketones are 4, which is still too high, but they're better, then you can just keep going with that regime, and it will almost, it will virtually always resolve the problem, because usually what will have happened prior to that point is that they'll not have been eating and they'll not have been taking their insulin because they've not been eating and they're not well, and they forget that they've been told always keep taking your insulin. So you can actually pull it back from quite high ketones by following that sort of process, and the junior doctor FAQ has that flow chart for what you would do in that situation. But using urine ketones to monitor it wouldn't work because there's just too much of a lag. And if you did give somebody 10% of their, or maybe even 20% if you're following the flow chart as a rapid acting bolus and their ketones went up, then that's a clear no-brainer that they need to go to the medical unit, or they're accepting, if they're refusing to go, then they're accepting that they're, that they're very unwell and that it's probably not going to resolve itself. Happy to talk about that later if needs be. So if they're on an SGLT2 and they've got urine ketones, then really stopping the SGLT2 is the main action that's required. So if you're not overly worried about a ketoacidosis, but they've got some urine ketones, then stop it, encourage fluids, food if they can manage, because you want the food so that they'll release some insulin themselves, plenty of fluids, and without the SGLT2 in the system, then they can recover from that. And ideally, you would, in an ideal world, you would be checking to see that ketones were settling. If somebody's not got type 1, or you're not concerned about insulin deficiency as an underlying reason for their diabetes, and they're not on an SGLT2, then urine ketones are probably just, that they're not eating, and they'll resolve when the person hopefully starts eating again. So really, we're really trying to avoid euglycemic decay by following sick day rules, so withholding if they are acutely unwell, clinical dehydration, and probably stopping early when patients start to describe reduced appetite. If they're losing weight, then definitely there's they might be better on glycoside or something if they do need something. But there's one scenario when you might have to think twice about stopping it, and that's if the patient has heart failure. So these medications, originally used for diabetes, worked really well. But surprisingly, the cardiovascular outcome trials showed really dramatic improvements in cardiovascular outcomes, all-cause mortality for empagliflozin in the original study, and almost, I think, a 0.65 hazard ratio for heart failure in the trials. So subsequent to that, they did a big heart failure study with dapagliflozin, which is one of these SGLT2 inhibitors. And this was for people with and without diabetes. So only 45% of the trial participants had type 2 diabetes. And they were a frail, ill bunch in this trial, much more so than the other ones. So, unwell with heart failure, able to have an EGFR down to 30, systolic blood pressure of 95, and if they had type 1 diabetes, they weren't allowed in it. And again, really significant benefits, cardiovascular death and worsening heart failure events. So this is now licensed for heart failure with reduced ejection fraction for symptomatic heart failure down to an EGFR of 20. So from a palliative care point of view, if they are being prescribed this class of medications for heart failure, or they're at risk of heart failure. So if you see that they've got a big cardiac history, the SGLT2 might be sort of masking heart failure and sort of treating it without them ever actually getting the diagnosis. And if you stop it, patients can develop pulmonary edema and become unwell from a heart failure point of view. And that did happen when the original canagliflozin study was published. There was a slight signal for digital foot to toe amputation. So one of the foot clinics took all their foot patients off their SGLT2s, and then they all turned up in medical receiving 2 weeks later in heart failure. And many of them weren't known to have heart failure, but they just developed it and it had been managed. If the EGFR is less than 45, then the implications for blood glucose control is less of an issue. So the way it works in diabetes is the way it works in the kidneys, and the excretion of the glucose below an EGFR of 45 and certainly 30. There's not much of that going on, but the renal protection and the heart failure mechanisms are still working. So you might find that you can stop the SGLT2 from a diabetes point of view at the lower EGFRs without making too much of a difference, but you do just need to be mindful of their heart. So I'm just going to talk a little bit about the other new medication that we're using, glucagon-like peptide receptor agonists, GLP-1 agonists, GLPRA, you might see that written down. And these are the ones that are commonly used in Glasgow. So the top one, exenatide, was the original one, and that's used much less, but there are older people who don't want to change might still be on it. And the Byetta was daily, the Bidurion was weekly, sorry, that's a typo there. Liraglutide is Victoza, and that's daily, and the two that are really being used, and in particular dulaglutide, is a weekly one. Semaglutide, weekly, but there is an oral daily version of that now. So that's what they look like. These two, the liraglutide and the semaglutide, are just like insulin pens. You have to screw the needle on and dial it up. And you maybe had patients in the unit with dulaglutide is different. It's a single-use pen. The needle's inside it. So it's often the one that we'll use in older or frail people because it is so easy to use. So GLPs are another wonder drug. It affects lots of parts of the body. It's been shown to reduce cardiovascular events, particularly in people with, who are high risk of heart attacks and strokes, even if they haven't already had one. It generally improves blood pressure. It affects works in the brain, so people's appetite reduces. And it works in the gut, and it slows the emptying of food from the stomach, particularly when they're first started. So the combination of sort of feeling full sooner and a reduced appetite can actually lead to quite dramatic weight loss. and they're actually licensed for weight loss without diabetes, but they're not SMC approved, so they're not prescribed on the NHS, but there are plenty of ways to get them privately. They work really well for diabetes. Blood sugars usually come down, patients lose weight, everyone really loves them. However, we are seeing some patients who are being referred to gastro because of their weight loss and the feeling of fullness in their stomach. You know, hopefully that'll settle down once gastro start to recognise the pattern, or GPs recognise the pattern. But it's probably, from your point of view, you know, from a diabetes point of view, good glycemic control, cardiovascular protection, weight loss, safe and renal impairment, and no hypo risk. So for us, you know, it's a great medication. However, GI upset is quite common. Diarrhea, feeling of fullness, food sticking in the gullet, nausea, vomiting, and weight loss. So I suspect from a palliative care point of view, you probably are thinking about reducing, because you know, you can reduce the dose, or stopping, particularly as oral intake is reducing, or if weight loss is not desirable, and they can exacerbate GI symptoms. There might be, and I don't know if this would be a relevant scenario or not, but when people do stop them, they find that their appetite comes back, sometimes quite markedly, and I suspect maybe for head and neck patients, or for patients who can't eat, that would probably be quite a distressing side effect of stopping the GLP-1 receptor agonist. But I suspect they probably do need to be stopped, but it's maybe something to be mindful of if you're having that conversation with a patient. So this is just a so I'm going to have a drink of water. Excuse me. I'll let you look at that while I'm. So this is just a summary table of the medications which don't cause hypo. So I think about medications as hypo-causing and not hypo-causing. So gliclazide and insulin are really the only two that cause hypos. Metformin, we've already talked about. Gliptins, I suspect you're quite familiar with because they are safe, they're really well tolerated, they're just not particularly effective. The HbA1c change is about 6, but if somebody's close to target, that may well be enough. Pioglitazone, you'll still see some patients on that, and I think you would stop that unless there was active indication. But be mindful, it can take about somewhere between 2 and 4 months for it to come out of somebody's system. So if somebody's still with us after that timescale, you probably do need to have sort of booked in a safety net of an HbA1c check, because I have had a situation where I stopped it in a 90-year-old gentleman, and whose HbA1c was 50, and I booked a 4-month HbA1c, and 3.5 months after I stopped it, he was in medical receiving with a lab glucose of 41. So my lesson from that was book a 2-month HbA1c, not a 4-month. But I didn't expect it to be so active. So if you are stopping them, that's fine. It's probably the right thing to do. But just, you know, if they're still with you down the line, then make sure that there's a safety net. Gliptins, the glyphosins we've already spoke about, and the GLP-1 receptor agonists. Gliclazide and insulin sick day rules are slightly different because it sort of depends on what the problem is, whether you would be withholding or potentially increasing them. So if somebody is fasting, they've got recent weight loss, end of life, severe AKI, blood glucoses will usually fall. The doses often need reduced, especially the rapid acting components of regimes. So your mixed insulins that have got background and fast acting, you might want to convert just to the background aspect, and that's discussed in that junior doctor's FAQ. You would be more mindful of doing that if the control was already tight. And then just a reminder, you never completely stop long-acting insulin in type 1. However, if somebody's got severe infection or they're on steroids, their blood glucose can often rise, so increased doses may be required. And one thing which I've not spoken about, but we can discuss at the end, is NJ feeding and the effect that that can have on blood sugars, because we will have people who are on metformin and their control's okay, and they end up on NG feeding and they end up needing quite high doses of insulin. So conversely, if that feeding is stopped, you will very quickly need to quite aggressively cut down any of the insulin that's covering that feed. So, end of life care actually gets quite straightforward, I think, towards the end of life, if it's the last few days, because you stop the monitoring. This is all your bread and butter. You're familiar with this. You're looking to move to a once a day insulin. Accepting blood glucose is up to 20 millimoles per litre, and DSN involvement as required. And I hope that you all feel quite comfortable contacting the diabetes nurses. I know that they're always happy to help. So if you don't do that, feel free to be using their expertise. So this is an algorithm from that document. And it's similar to what's in the FAQs. So somebody has, for example, type 1 diabetes, you're continuing your once a day, and it's giving you quite specific guidance about what to do. Check your blood glucose once a day and titrate depending on the results. If they've got type 2 diabetes, stop your tablets and your GLPs. Consider stopping insulin individually if the individual only requires a small dose and their blood glucose is less than 10. And then again, it's giving quite specific guidance. In terms of which background, so that guideline mentioned Lantus, Tresiba, Shimal and I had mentioned in the preceding slide. Lantus, I think, would be the default. I mean, would that fit with yourselves? I don't know if anyone can nod. Yeah. Typically lasts up to 24 hours, once a day dosing, ideally at the same time every day, commonly used, everyone's familiar with it, everyone knows what they're doing with it. Tresiba's in that guideline. So I thought I'd give, and we are increasingly using it in the community, so people will be coming in on it. And it's an ultra long acting insulin, so it typically lasts 42 hours, although it is still once a day dosing. It comes in 2 strengths, so it comes a U100, which is 100 units per mil, or U200, 200 units per mil. So you can't be, withdrawing it and giving it with a syringe. It has to be with the pen. Takes 2 to 3 days to reach a steady state. And although the dosing is once daily, you've got a really wide 16-hour dosing window. So somebody normally takes it at 8 in the morning and they forget one day, they can take it at 8 o'clock the next night and then still take it at their correct time at 8 o'clock the next morning and have their flat background. I would say Atlantis is definitely better if they're end of life, because there's just much easier daily titration. There will be a lag with the Tresiba. If you reduce the dose one day, you've still got yesterday's high dose in your system the next day. There might be a benefit if somebody's going to go home, because it does give the district nurses a bit of flexibility about administration. And if somebody has type 1 and Lantus for them doesn't quite last the 24 hours and the district nurses are 3 hours late, then potentially patients can run into trouble. So it does have a specific role, but it's probably something you would be seeking advice for if you're unfamiliar with it. The other one, which I haven't put in here, it's probably less commonly used, is Toujeo, which again is a longer acting insulin that's concentrated. So that's U300, 300 units per mil. And usually prescribed if people are on really high doses, just to reduce the volume that's actually being infused, is being administered. So if you are switching basal insulins, we would usually, unless the blood sugars are very high, we'd usually reduce the doses by about 20 to 25%, just from a safety point of view, and then you could titrate back up. I've just realised I thought I had a case, but I think I did. Sorry, I missed this. This is I've just got some cases just to finish up. I'm just looking at the time. If you've got somebody with type 1 diabetes, end of life, and they come in on Levemir, 12 units twice a day, and Mar-Apr, 3 to 6 units with meals, and their blood sugars are really all over the place, then you would be, looking to try and get that person onto a once a day insulin, which what we're really saying would be Lantus. And so in somebody who's on 12 units of Levemir morning and tea time, so their total dose is 24 units, and we're thinking of taking 25% off, then we're thinking of 20 units of Lantus. So depending on their blood sugars, you could probably just omit the evening one and just give it the next morning. It probably doesn't matter that much, and I wouldn't lose any sleep over it if they got their evening Levemir and then their Lantus the next morning, because the Lantus is going to take 4 hours to kick in anyway, so even if there's an overlap, so there's probably no right or wrong answer. But if their blood sugars are running high, you maybe would just give the Levemir and then the Lantus the next morning. If things are actually quite tight, you would maybe just skip the Levemir. And then titrations in 10 to 20% increments. So if you're kind of close to target, 10%, if you're miles from target, 20%. And that's really useful because if somebody's on 100 units of Lantus, which does occasionally happen, tweaking by 2 units isn't going to make any difference. You're going to be increasing it by 10 or reducing it by 10. If you're doing mixed insulins to basal insulins, so you would need to know the components of your mixed insulin. So Humulin M3 is probably the most common one that we're all used to. 30% fast-acting insulin, and it's not Humalog, it's not rapid-acting insulin, it's just fast-acting insulin that's in it, and 70% is the longer-acting background. So if somebody's on Humulin M3 and they're not eating, then you want to remove that meal time, that 30%, but probably keep going with the background. So if somebody was on 25 units twice a day of M3 and isn't eating, so that's 50 units total daily dose. So a third of that means that 15 units of it's fast acting. So we want to get rid of that. We want to keep the 35 units of long acting, and then we'll take a 20% off just for safety. So that person would then be prescribed 28 units of background. And probably if they're in the unit and they're going to stay in the unit, you would use Lantus. If they might go home or they might start eating again, and they might end up going back onto their M3, then you might want to just keep going with the Humulin I, because then the conversion back to the Humulin M3 might be a bit easier. So that would be the same for Novamix 30s, probably the other one. Very occasionally you see Humalog Mix 25, so that's got 25% fast acting. And the only other one I can think of would be Humalog Mix 50, so that's half and half, so that's 50% fast acting and 50% background. Again, there's more examples of that in the Junior Docs FAQs. So I think I've got another 2 cases in total, and then we'll stop for questions or comments. So this is an example of somebody who's on tablet-controlled diabetes. They're on metformin and alogliptin. The HbA1c 4 months ago was 62, but they've come in, they've been started on Dex in the morning only, and their blood sugars are going high through the day, but are still low in the morning. So this is steroid-induced hyperglycemia in somebody who's known to have type 2. So the Trend Diabetes UK document has a similar flowchart. It's quite complicated, but it does, if you follow what it says to do, it is good advice. This one's just a bit more straightforward. It's directed for being on the wards generally, so you wouldn't be thinking about starting a VRI or a sliding scale. But broadly speaking, if they're not on glycoside or insulin, you would be starting just a 40 milligram of glycoside once a day in the morning, and you would up titrate depending on their blood sugars. And what's different to the normal prescription of glycoside where you would normally go 160 twice a day as the top dose, you can front load the glycoside in the morning, because what you're trying to do is match the way that the steroids affect the blood glucose, and that peak in the early afternoon. If the blood sugars remain elevated, and this is saying above 10 on maximum dose, you might say 12 in your unit, then you would just commence insulin, 10 units of Humulin I, and then you would titrate that daily. It's not nice to have a blood sugar above 15. People have a dry mouth, urinary frequency, feeling thirsty. So it's probably something to do sooner rather than later if the steroid dose is not going to be stopped anytime soon. So just move on. And if somebody's blood sugars are much higher than that example, so up into the 20s, still worth, and it's a steroid-induced, scenario, it is still worth trying glycoside, because actually it might work. So you would maybe, rather than going to 40, you might go to 80, and you would quickly titrate. And because of the way glycoside works, the sort of day that it's in your system, you can titrate it daily. So if you're getting close to target, you might want to wait a couple of days to see a pattern. But if somebody had 80 milligrams of glycoside with these blood sugars and they came down to sort of, 10, 14, 16, then the next day you would just go up to the 160. And if it's not really doing it, then by day 3, you might be on to Humulin I. So this is an example scenario that I've seen, not a misdiagnosis in the hospice, but a misdiagnosis in the, you see it from nursing homes and sometimes actually in the wards. So if you can imagine an elderly gentleman who's come in with mobility and pain, the hope is that he'll go home, but he's come in for a bit of respite and just some symptom management. He's had diet-controlled diabetes for 10 years. An HbA1c a few months ago was 48, and his blood glucose on admission was 6.7. So during his stay, he develops a chest infection, gets some antibiotics, his chest improved, but patient deteriorates over days, confused, drowsy, lethargic. Somebody does use an ease, the sodium's low, and there's a bit of a mild AKI, and not really sure what's going on. And then somebody actually thinks to do a blood glucose, and it's 41. I've seen a scenario in the hospital where somebody's lab glucose got to 79 before it was recognised that the patient had developed HHS, or what we used to call honk. So it does happen, and it comes on slowly, and it over weeks rather than days. And it's often in patients who have a diagnosis of diabetes, but they're not on any medication to remind people to actually check a blood glucose. And they may not have been on medication for 20 or 30 years. And what somebody with HHS will look like, so they're hypovolemic, so they'll be dry and reduced oral intake. They've got marked hyperglycemia, so typically over 30. And part of the diagnosis of HHS is that they don't have significant ketones and they're not significantly acidotic, because that starts to then have a mixed DKA picture, and it's different. The patients still have insulin, but they just become so dry, they're losing so much fluid in their urine, and they can't keep up with it. And they will have a high osmolality. So you can ask for that. You can phone the labs and say, can you add an osmolality onto that using ease I sent? But you can actually calculate it if you've got a using ease and a glucose. And just in this scenario, and for other patients, beware your meter's higher limit. So the meters in the hospital will read, beyond 27.8, it just says greater than 27.8. But we do sometimes see staff just writing down 27.8. So if you see a sheet and it's all 27.8s, they could have a actual lab glucose of 60 or 80 or anything. So it's really important, if you have that scenario and it's not coming down, in the wards they're supposed to do a lab glucose, but obviously it's not practical. And if it comes down, that's fine. But a scenario where you can run into trouble if you give a correction dose and you check their blood glucose 2 or 3 hours later and it's still above 27.8, and the patient gets another correction dose and they get another correction dose, but what you don't know is that it's gone from 45 to 35 to 28, and then you give another dose, and then your patients can then have a hypo. There are some meters that only go up to 22, so it's just worth knowing what your ones go up to, and bearing that in mind. I'm going to go back because I think I've missed a slide. Yes, so who's at risk of HHS? So as I've said, typically known, patients will often have lost their thirst drive. So that can be because of cognitive impairments, patients with dementia, or just that they're not well, and if they're unable to obtain water for themselves. So people who have a thirst drive and have access to water usually won't develop HHS because they can drink enough to keep themselves hydrated. But what happens is the patients will get an illness which affects their oral intake, and then HHS develops. And we see this commonly. Patients have been treated they have a urine infection which they're treated, but because there's ongoing incontinence, then another course of antibiotics are given, and then another course, but of course the incontinence isn't because of the urine infection, which was the initial problem. It's because they're so hyperglycemic, and they've just got urinary frequency and osmotic symptoms. And the point about the low sodium is that you can get a pseudo hyponatremia. So that's where it's a fake low sodium if somebody's got a high glucose. So for every 5 millimoles of glucose is above normal, the sodium can be reduced by 1. So the patients aren't genuinely low in sodium, and actually in HHS they're obviously, they're actually often sort of technically high, but it's been brought down by the high glucose. So I'm interested to know what the policy is in the IPU for checking a blood glucose in patients who are known to have diabetes but not on any medication, and whether this is the type of thing you would pick up easily, because if these patients got glycoside promptly and some fluids, then things are just completely averted. And that's another slide. So that was the couple of cases that I'd put in. I've just put the phone numbers for the diabetes hubs that I think would be local to you, or that would have patients that would be coming in to Accord. Nobody will ever answer these phones, but people will get back to you quite quickly with them. Some of them just go, they go straight to an answer phone message, and that's just the way they manage the demand. So
I think we'll just stop it there, Debbie, because I'm conscious, as I said, I'm conscious you've got your other meeting to go to, and it's just to give people an opportunity to ask any questions. We will make we will make that whole recording available to you all to have a look at. And it was just to see if there's any questions. I have to say that after the first group that you came to, Debbie, you made a couple of changes to practice within the unit, just because it was so current and up to date. So maybe just open it up to all of you. Has anybody got any specific questions for Debbie round about anything at all that you've heard or listened to, or any queries, concerns?
Just while everyone's thinking it, the guidelines and the SGLT2s, it keeps changing, and I think I can see that the dapagliflozin, I think it is, I've put in for approval for SGLT2 just in CKD, so that's with or without diabetes, and there's good evidence for it, and I think it's going in front of the SMC in May. And if that's approved, that'll be another whole host of elderly patients being put on these medications. So it'll be just another decision to make when you are down, trying to guide medication down titration at the end of life. It keeps changing.
Any questions? I know, sorry, Amy, were you going to ask something there, or were you just sorting your camera? I thought you'd put your hand up. I know certainly that within the unit, it's always something that, and I know the medics after Debbie did her first session, our medics have had a bit of a chat about things. So it definitely, I think it definitely has made us sit and think about what we do. one of the things that did come up in one of the last sessions was the glucose monitoring of the patients that were on steroids. For those of you that work in community, perhaps, that was something that came up, and it's something that's one of the bits of practice that the community team are kind of looking at. Should we be keeping an eye a bit more on the patients that we start on steroids?
I think that's maybe one of the cases after this point, so it maybe hasn't.
Yeah, maybe hasn't got to that stage yet.
Yeah, definitely something to be thinking about.
Yeah.
Maybe getting with the questions this time.
No questions. Nobody get anything at all to ask.
It's all crystal clear.
All crystal clear.
I was just going to ask about the community. I was just going to ask about the community with steroids, because I've had a few patients recently who have been trying to do their blood sugars starting steroids. But I don't know, in other areas I've just started at St Vincent's, so it's difficult to have the equipment to check people's blood sugars when you're in, from a specialist nurse point of view. So is there a kind of routine that other people do to start people on steroids, or?
I think that was one of the issues that was brought up with the first group, Helen. It was a couple of the community team, and I think that's maybe something that they've looked at, and they were either going to get a blood glucose monitoring equipment for the team to take out. June, I don't know, I know you, June, you're there somewhere. Has that been progressed any? Do you know, June?
Yeah, it's not really progressed. It was something I brought up at the meeting.
Right, okay.
Because I'd asked the practice nurse to check someone's blood sugar. They were on steroids, and there was a bit of a hoo-ha about getting a monitor because they're prescribed per person, and all they would do is really a blood glucose.
Okay, thanks, June.
Susan, there's a hand up.
Jackie and Jane, you guys.
Hi there, it was just to say we would ask the district nurses to do the blood monitoring for us.
Okay.
And we never usually have any issues with that.
Right, okay, thanks, Jane.
There was an issue with that as well, Jackie, because they don't carry a monitor seemingly, and it's the patient's own monitor that's used. That's
interesting. Our district nurses do. They have their own wee individual one.
Right.
Whether they're meant to or not, I don't know, but they do.
I suppose it's just down to local practice maybe, but it was certainly something that's made us think, is it something that you guys should maybe be more aware, not more aware of, but maybe more involved with? Lindsay was going to have a look at it, I think.
Yeah, it would be good. I'd be really interested to hear, how your discussions go, because it'll be relevant across Glasgow.
Absolutely, yeah, absolutely. Thanks, guys, for that. Anybody else get anything? Thanks, Helen, for bringing that up. Anybody else get anything? Any burning issue for Debbie before she rushes off to our next meeting? At least you won't have to sit and listen to yourself, Debbie.
Not pleasant.
No. Okay, brilliant. Thanks, and I really appreciate you popping on, Debbie. Really appreciate your time.
No problem. Take care.
Okay, thank you. Bye. Bye.
Bye.
Okay. I know there was quite a lot in that recording, and it's a bit difficult when you've got a recording and that you know the person's coming on board as well. We will make that the slides. We've got our slides to share with you, but we've also got the whole recording will be made available to you. And I know some of the pharmacists have looked at that and have shared that with some of the medics across more than just our hospice. I think quite a few of the medics in the hospices have seen it. And then there's a couple of things within, I'm sure it's within the inpatient unit, and maybe Rebecca and Joanne will maybe clarify this for me. But I think there's been a change to the insulin maybe that you're storing or that you're using. because of that. I think you've moved to are you now moving to Lantis? Yeah, Joanne's nodding, yeah. And it's just as a result of having these updates, it lets you see. And I think the other thing that struck me about it was the amount of elderly people that you're potentially going to see, and the way things are moving on, and the way treatments are moving on, and people have been using them. And she's just, I think one of the things that she flagged up was the amount of people that have done something for so long, but as they become more cognitively impaired as they go on, then it gets harder to manage. But no, I thought it was really interesting. So I think, well, I certainly learned loads, but that doesn't mean to say that's not because I'm so far removed from the clinical side. But anyway, I hope you found it useful. I know it's maybe quite a long morning because you've been sitting listening to Elaine with all the things from pharmacy, and then you've had the diabetes. So we're going to break for lunch. And Fiona, when do you want them back?
Great, Susan. Thanks very much, everyone. So if we stop, we'll stop now and come back at 2:15. And Susan, we would start with your session at 2:15.
2:15, right, okay.
2:15, and then we will have Lindsay McNeil from Accord Hospice coming on to do the opioid work, if that's okay. Can I just check, because Helen, you looked like you had your hand up, then took it down, but I'm wondering if we've answered your question or whether there was something else you wanted to ask.
I'm just quite conscious of the fact, probably this is maybe not the right thing to say, but I'm a previous district nurse and then I've moved into this role. So I have a kind of understanding of referrals to the district nursing team. And I think they would feel a bit more overwhelmed. Their amount of workload is substantial. So I think we would need to maybe get together as a group and see how we're going to look after our patients that are on steroids, because lots of these patients aren't known to the district nurses, and I think we may get in the Renfrewshire area a bit more of difficulty, because if you're then putting on the patients that you've got on steroids as well and having to have guidelines and protocols for that too, I just think it might be difficult. And the other side of it is, if we take on doing blood sugars when we're in, I know that may not be what people want to hear, but you do need to have a control system with the systems that you need, your blood sugar machine and things.
Yeah.
I found that video really, really helpful, but there was a huge amount of information that you're trying to listen to and take in. So I'm really thankful that that recording is going to get sent on, because I think I need to take quite a bit more time to actually take all the information from that in and change practice, kind of thing.
Yeah, definitely. I think there's so much information, and although she talked about palliative care and end of life, I think it was more of just a kind of a current update of how they're managing it. The other thing that she did mention as well was her and the team, the diabetic team, as a resource to try and get help if you need it. But she also did admit that no, they wouldn't answer their phone because you could never get an answer with the diabetic team's phone. But they will always get back to you. So it's a case of, if you do phone, she did reiterate that. She said if you do phone and you get an answering machine, then don't let that put you off. Leave your message and somebody will come back. But no, Helen, I think that's a couple of good points you brought up. And it's probably something in our own locality that we need to maybe have a look at going forward, rather than just deciding to do something on our own. But thanks for that, Helen, that's really good. It's good to get both sides of it. Okay, this session is really just about incident reporting, and it's probably just a reminder about patient safety and what we all have to do when we're dealing with adverse incidents. I'm going to share a couple of slides and then we'll get you to answer a couple of questions, and I'm going to share the slides, and hopefully you won't all disappear. Can you see that? Okay. Now it's me that's got the technical problems.
I'm glad we've handed over that reign, Susan.
The joys, the joys. Okay, what's this? So basically this session, and I know we've only allocated half an hour for it, we did quite a bit of work in this last year, but I think it's something that we probably need to keep on the agenda all the time. And it's something that we're all involved with in different aspects. I'm obviously involved in it and kind of in the background. I'm not involved with the face-to-face incidents that happen, but I'm involved with collating them and doing all the kind of stuff in the background. So probably going to start with, can you see that okay, or is that getting blanked out for the video?
Yeah, you can see it.
Is that okay? Yeah.
Yeah.
I thought I would probably start off with this slide, just giving you an idea of what the bigger picture is around about patient safety and avoidable drug errors, about the work that's actually happening and the work that influences what we do at local practice. So in a global, even in a global scale, about 5 years ago, the World Health Organization recognised that with the amount of avoidable drug errors that happen across the world in all settings and all, whether it's hospitals, community, etc., then they felt that there was something that everybody really needed to address and take on board to try and reduce serious harm from medication errors. And what they wanted to do was try and achieve a 50% drop in the incidence of avoidable medication errors over the next 5 years. There's been a huge amount of work that's gone on kind of on a global sense across the whole world about trying to reduce drug errors. And that then takes us down to the next level, which is at national level. And that's where a lot of the work that influences what we do on a daily basis comes from, like the National Patient Safety Initiatives that go on, a Quality Improvement Hub, and there's been lots of patient safety initiatives have been introduced nationally across the board in the UK, but also within Scotland as well. So it kind of cascades down from WHO, and then it cascades down to the national side of things. And then a lot of the stuff that comes out, the iHub and the patient safety initiatives, comes down to land in, I suppose, lands in our desk or lands in my desk, which then probably lands at your doorstep. And it's things like making sure that we've got a robust incident reporting system, making sure that we use a lot of reflection, we learn from incidents that have happened, and that's all tied into audit and quality improvement as well. So you can see how it's all sort of related. The one thing that I want to probably stress is round about the incident reporting, and I'm pretty sure all the hospices or all the organisations probably follow a very similar way of dealing with incidents. But the kind of ethos and the principle of incident reporting for drug errors is round about honesty and openness and no blame, a culture of no blame. But although it's a no blame culture, that doesn't mean to say that if just because it's a no blame culture, it doesn't mean to say that that doesn't mean no responsibility. People still have to take responsibility for their practice, etc. However, if you've got an open and honest culture of reporting incidents, the chances are there's more chances of more honest reporting happening. And it's about looking at the incidents and it's about learning from them. Further on, once we kind of get past the next bit, I'm going to share an incident that's actually happened within our organisation. And what I would, when we start to talk about it and when we start to kind of discuss it, what I would like to encourage all of you that maybe weren't involved in the incident, what I'd like to encourage from you is that open and honest. And although you can bring up points, try not to be too critical, because bear in mind that there might be people in the room that were actually involved in the incident. And I take my hat off to the organisation for allowing us to discuss this. It's not, didn't cause the patient any harm, but it's a really, really good example of how an adverse error can happen, but involving more than just administration. It involved prescribing, and it involved transcribing, and it involved administration as well. So it's a good example of how things can happen. But we learned a lot from it, but just keep that in mind when we're talking about it. So just before we go on to the next slide, I'll just stop sharing and I'm going to let Jackie put a wee poll up for you, where a wee quiz comes up. And I just want you to maybe answer these questions. So the first question is, how many medication errors do you think are made on an annual basis? So you've got a choice, you can pick one of 3 options. So thinking about, and I'm talking about nationally, not just within the hospices, not just so within all sectors, how many medication errors do you think are made annually? Okay, and then the next question is, in what sector do most medication errors occur? So you've got a choice of care homes, hospitals, or primary care. And then there's the third question is, what do you think is the approximate cost of avoidable medication errors on an annual basis? So how many? This isn't that. I was going to say there's no right and wrong answers here. This is just a wee bit of awareness. It's just to see where you think you are. So still got 1 or 2 to answer. But that might be because of the rooms, Jackie, isn't it? 14.
So that's us. I'll just send the.
That's it?
Yeah.
That's fine. That's great. If you can just, if that's everybody done, then just can you share?
Yeah, you see
the results. So okay. So the first question is, how many medication errors are made on an annual basis? So I was going to say the majority of you put 100 to 200 million. The quarter of you put 75 to 100 million, and about 30% of you have put greater than 2 million. No, not 2 million, 200 million. So the answer is actually greater than 200 million, which is quite scary. I was a bit kind of, oh wow, that's a huge amount. So there we go. So the second question is, in what sector do most medication errors occur? The vast majority of you have put down hospitals. Some of you have put down primary care. We didn't put hospices in because I couldn't find any stats about hospices on a national basis. And none of you have picked care homes. And actually that's the correct answer. It's care homes that the majority of avoidable medication errors occur. So again, this mirrors what happened in the first couple of workshops as well. Everybody said, oh, it has to be the hospitals, but actually no, it's the care homes. And the third one is, what's the approximate annual cost of avoidable medication errors? And it's the 100 million, it's about 98 to 100 million that's estimated that actually costs. So there you go. Anybody surprised at any of these? Did that surprise you at all? I think the number of avoidable errors kind of took me aback. So that, I'll go back to sharing the slides, because that that comes from a paper that was done in 2020. It's actually based in England. It's not in the UK wide. It's very difficult to get statistics for the whole of the UK. So that was a paper done in 2020 about the effects of avoidable adverse drug errors. Over 200 million are made every year. They happen at every stage of the process. The majority of them happen during administration, but it happens at prescribing, dispensing as well. And the next point just talks about the error rates were lowest in primary care, highest in care homes, and about 1 in 5 medications were in hospitals. And as I say, I couldn't get any specific information on hospices. the good news about all of that is that the vast majority of them are relatively minor and they don't cause serious harm. There's only about 2% of drug errors that actually cause serious harm to patients, which is the good news story out of all that. And then the last point is that they calculated that avoidable medication errors cost the NHS about £100 million every year, and an adverse effect on lives as well. So it's a significant issue. It's something that we all have to be aware of, and it's something that we need to think about in our daily practice. In comparison, I've given you an example. Again, this is based on our adverse incidents at Accord Hospice over the last 12 months. And you can see that the numbers are drastically, I mean, the numbers are very, very small. And I would say that the last 12 months, the numbers are probably on average less than what we have seen in previous years. So we're only talking about roughly about 14 incidents that we have recorded as adverse incidents. Some were dispensing, some were prescribing, some were administration, and some were down to recording as well. But what you'll find in your own organisations, that whoever it is that deals with the kind of patient safety side of things will have a register of all the adverse events, and what you do in the background is kind of look at, you allocate what category they go into, and they're reported through drugs and therapeutics, and there's reflection and learning takes place from most of them as well. Some of them are so minor that there's not a huge amount of learning to take place, or there's not a huge amount of reflection, but it's all fed back through the kind of quality and audit department. But each of the organisations will do it in a slightly different way, probably. So going on to the next slide. What I'm going to do is I'll share the slide. I'll share the slide describing the incident, and I'll talk you through what actually happened, and then we can maybe have a wee bit of discussion or a wee bit of reflection on what actually you think, or I think be honest about it, but just bear in mind that it is a real incident. So moving on to that, the incident was a patient was transferred to the inpatient unit from the acute sector on the 19th of August. 0.5 micrograms of alpha-calcidol daily was included in the list of their current medications. When they came over from the hospital, they came with a copy of their Cardex that the patient was getting, and the alpha-calcidol was included as 0.5. That's what it should have been prescribed. The meds rec process was carried out by the admitting doctor, and they used both the hospital Cardex that they had come over with, and also they had accessed the electronic care summary on portal to see what drugs that he had been on previously. The hospice Cardex was written, and alpha-calcidol 5 micrograms was prescribed. So have you noticed the error yet? Fiona, can you just keep an eye on folk, because I can't see everybody?
Yes, I can, Susan. I'll keep an eye on it. I'll keep an eye on in the chat as well. Can most of you see what the error is so far? If you look at it. Do you want people to put in the chat facility what?
Yeah, you can do it. Okay. Put it in the chat, or just put up your hand, one or the other. Just to get an indication of you, to see where you are with the picture of what actually happened.
Okay, so
yeah, so you can see. Okay, that's fine. That's good. Yeah. Yeah, you've got it. So basically, the person was prescribed 5 micrograms of alpha calcidol where they should have been prescribed 0.5 micrograms of alpha calcidol. So that's the kind of the main incident that what happened. However, as we move on, on the 25th of August, so he was transferred to the inpatient unit on the 19th of August. On the 25th of August, it was then noted that the prescription actually said 5 micrograms. And as soon as that happened, then the incident was immediately reported and it was investigated. There was everything, the wheels went in motion immediately that was noticed. As part of the investigation, the registered nurses that were involved in the administration of the alpha calcidol confirmed, now this is where it gets a bit complicated, they confirmed that although the prescription stated 5 micrograms, then the correct dose of 0.5 micrograms had been administered. Okay, I'm going to stop sharing actually because I want to see people's faces. I don't like speaking to a blank screen. So, the patient was admitted on the 19th of August, was prescribed 5 micrograms of alpha calcidol instead of 0.5 alpha calcidol. On the 25th of August, this was noted that the prescription had said 5 micrograms, but on investigation, the registered nurses confirmed that although it said 5 micrograms, they had been administering 0.5 micrograms. And that was verified by looking at the stock levels, etc., of the actual alpha calcidol. So I'm going to stop you there. I'm going to stop there and just give you a bit of time, or just tell me what your thoughts are. Keep bearing in mind that you've got open, honest communication. This was a genuine error that happened. What are your thoughts? What do you think's happened? To get to this stage, what do you think has happened? Anybody get any thoughts? Trisha?
I think obviously that was almost a week that the patient had been administered the medication without it being noticed. That obviously the nurses hadn't been properly checking the dose on the bottle or the box, whatever it came in. And had they sort of noticed that, they would have realised, wait a minute, that's far too many of these I need to give to make that dose that's prescribed, and it would have been picked up sort of sooner, where they were just glancing at the 5 and not seeing it.
No, thanks for that, Trisha. I think there's a couple of comments in the chat as well. Yeah, Ellen's saying that the 5 R's are the R's, the rights, the 5 rights, or how many rights of the drug were not followed, and the girls from PPWH saying that RN had not read the prescription properly and just issued what usual dose is. Yeah. So
Susan, Jane, Jackie have got their hand up.
Okay, sorry, Jackie, Jane.
I'm just wondering, do you use the pod systems that the medication was sitting in the pod?
Yeah. So pods are used. Yeah. And I think it's hindsight is a wonderful thing, and when you read the incident and when you read back on it and you think, my God, how could that happen? And I think there's a bit of that comes into all incident reporting, but it's trying to look beyond that and think, right, okay, what has happened here? And I think all the things that you've said are absolutely right. But how many times do you do that? That you go by, you sort of maybe go by what the person before you has done, etc. And it just becomes kind of normal practice. Anybody else got any comments?
There's something else cropped up here in the chat.
Okay.
From Hedy, it's quite for us because we're quite far away from the screen, Susan, so I don't
No, that's fine, I can see it. So Hedy's saying, have looked at the tablets come in and have given the one tablet. If the patient's own medication used, it would have said give one tablet. Yep. Yeah. And I think going back to the slides, when the alpha calcidol, the preparation, and this is where it gets a wee bit more confusion when you come to your drug calculations, but the preparation that was being used came in 500 nanograms capsule. So each capsule had 500 nanograms. So to give 5 micrograms of alpha calcidol with that preparation, you would have had to give 10 capsules. So automatically, what would that have done? If you were having to administer 10 capsules to a patient, what would that do? What would that make you think?
We're triggered you to ask the medics to review it because it seems a bit much to be given 10 capsules in one thing.
Yeah, it's an abnormal, it's something abnormal. So anything at all like that would have alerted maybe earlier recognition of what was happening, and that was one of the reasons. As soon as the investigation, I hate that using the word investigation when you're talking about incident reporting because it makes it sound as if you're trying to find out who did wrong and all the rest. It's I suppose it's just reflecting back on what happened and learning from it. So when all of that, all the information was gathered, that was the one thing that highlighted straight away that actually no, the person had actually got the correct drug, the correct or the intended dose of drug, but the prescription was wrong. So the major fault lay with the fact that the prescription hadn't been picked up, as in when the over a period of time, then this hadn't been picked up. Also, when they started looking back through about the information, it was discovered that this had happened at the previous place as well. So before the patient was transferred over to the inpatient unit, then this had happened prior to the person coming over as well. So what does that tell you about the meds rec process? So when the patient was transferred, they were transferred with their Cardex from the other setting. That Cardex was then the medicine reconciliation process was carried out by the admitting doctor, and they wrote up the new Cardex using the information from the Cardex that had transferred from the setting. What does that tell you? What has happened there? Where's it fallen down there? Tricia?
They seem to have only used one source to do the medrec from, which isn't safe.
So they've looked, although they checked the emergency care summary, there was no mention of the alpha calcidol in the emergency care summary. It was only the Cardex, and basically what has happened is they have copied directly the drug and the dose, the drug and the dose from the Cardex coming from the hospital. So what probably should she have done, he or she have done to avoid that? Obviously using a second source. Anything else? Jackie, Jane? Or did you get your hand up from before, guys?
No, that was
that's fine.
So thinking maybe actually looking at the physical medication, so the box of drugs, and looking at it from that and using that as your second source.
Yeah, thanks, Jane. Okay. Hi, Lindsay. Okay, so I'll go back to the slides and I'll share what happened after that. At this point, there was absolutely no harm to the patient at all. Calcium and phosphate levels were checked and they were normal, and there were no symptoms, etc. But it was decided at that stage that the patient and the family should be informed that this had happened, which I think is probably the correct thing to do, and that comes into your whole duty of candour, etc. The next slide is, if I can get it to work. So on reflection, when we chatted to the doctor and the nurses and the pharmacist, when this all came to light, there was a kind of a fairly frank, open meeting about it all. We chatted about the medicine reconciliation, and although there was no information on the emergency care summary, there was information about the alpha calcidol in nanograms on a previous discharge letter. So the lesson learned from there is looking at the meds rec process, then going back to your, yes, you need at least 2 sources, but what the doctor involved said when she was reflecting on it was that she should have paid maybe a wee bit more attention to the discharge letter, and had maybe not just gone and obviously just not gone and what the Cardex from the transferring organisation said. The nanograms and the micrograms, and again, we had a wee bit of a discussion about this in the previous workshop as well. Nanograms is probably something that we don't particularly work with on a daily basis. So had that confused things? Did the original mistake come from an error in the converting from nanograms into micrograms? So again, that was talked about as well. Talked about the error in the acute Cardex being transcribed, and we've talked about the amount of capsules that it would have taken as well. What was learned from that incident? From the nurses' perspective and from I think from everybody's perspective, we all realised that it was an incident that should have been picked up earlier than it had done. It probably shouldn't have happened, but it did happen. It was picked up and it was investigated really thoroughly. It was reflected on really thoroughly. So they were the good points. I think the take-home messages were we absolutely double check any dosages, prescriptions, especially if there's anything unfamiliar or unusual, and it's about the quantities as well. If any of the nurses have any doubts whatsoever about prescriptions, then don't hold back and not ask. I think it's always better to ask and better to check. Emphasise there was a bit more re-emphasis about the checking process, etc. And we've since done an audit on administration of medicines within the inpatient unit, and there was absolutely 100% compliance with all the rights. But that's where the audit comes into it as well. So we've now done a bit of work on that. The meds rec process and documentation has been audited, and there's been a couple of recommendations have been highlighted in that. So we're working on that just now as well. And I think from the medical staff's point of view, I think it's just highlighted how important it is to check the dosage on transfer and don't just take what's written on the Cardex. And I think the importance of learning and honest reporting as well came out of it. And it's all very easy to criticise and say, oh, they should have picked it up, or that should never have happened. It's accepting that it has happened. Luckily, there was no harm came to the patient. The patients were well monitored and they were communicated with very well. And we have learned as an organisation, as individuals and as an organisation, we've learned from it as well. So I think just to finish off, it's a whistle-wind tour, bigger picture and local practice. I suppose it's having confidence in your own medicine management practice. Seek any learning opportunities and support that you can. Try and maintain the no blame culture and try and help colleagues if you find somebody. There's absolutely nothing worse. I can still remember that horrible sinking feeling that you get when you make an error, when you make a mistake, or you haven't signed something, or you think you've done, and it's just awful. So sometimes your colleagues need a bit of help and support. It's encouraging reporting as well. And yes, we've got a no blame culture, but just remember the no blame doesn't mean no responsibility. We all have to take responsibility for what we do. And it's reflecting and learning from the incidents, which I think we have done And I think I take my hat off to the staff in the unit actually for saying, well, actually we're okay with you discussing this out with our organisation, because that's not easy. That's not an easy thing to do, to put yourself up for scrutiny. And obviously the audit and quality improvement goes on in the background to maintain things. I feel as if I've absolutely whizzed through that. Anybody have any final comments on that before we move on? Anybody get any observations, anything you think was missed or should have been dealt with in a different way? No. Interestingly enough, on the first workshop, I think it was the first one we did, one of the participants who had moved from a palliative care unit in the east, had recently moved through from the east, said that they had come across exactly the same situation with alpha calcidol in their previous unit as well. So I thought that was quite interesting. And it was to do with the nanograms and the micrograms, and the fact that alpha calcidol is something that's maybe not in the stock levels. No comments? No. You're all very quiet. Your blood sugars are obviously too high. Okay. I see Lindsay's joined us. She came in quietly there. Jackie, are you going to share Lindsay's slides, or do you want me to do it?
I'm happy either way. Do you want me to do it?
That's fine.
Yeah.
Lindsay, we've put, see when it comes to your case studies,
Yep.
your last few slides, towards the end, Jackie, when it comes to case study 1 and 2, what I thought we would maybe do is put people into breakout rooms and just get them to discuss the case study and answer the questions and then come back in. Does that sound okay with you?
Yeah, so do you want me to, I'll share up to that point and then stop sharing and then put them into 3 breakout rooms?
Yeah, 3 would do, yeah.
When I do that, then I can just share the slides again.
We should be able to share the slides into the breakout rooms, yeah.
Yeah, that's good, no bother.
Thanks, Jackie. Are you okay with that, Lindsay?
Absolutely. Can you hear me okay?
We can.
Yeah. So you just tell me when to move forward, Lindsay, okay?
Okay.
No bother.
Do you want an introduction, Lindsay, or do you want to introduce yourself?
It's fine, I can introduce myself.
Sure.
Here we go. I'm Lindsay McNeil. I'm one of the consultants here at Accord Hospice. And I think I know most people, but there are some people that I don't know. Please just shout out if there's things you want to ask as we're going along. But there's some interactive bits as we get through it. But just either shout in or put your hands up and somebody will let me know. I can't see everybody though, because I can only see about 3 people at a time because I've got a smaller screen. But I'm sure Jackie and Fiona and Elaine will keep an eye on anybody who wants to shout in. So I'm going to talk about the use of opioids and adjuvants for the management of pain. So for a lot of you guys, it'll be me teaching the grannies to suck eggs. So I do apologise, but there will be some other members of staff who are at different levels. So I'm going to just keep it fairly basic, and if it's too basic for some of you, I do apologise. I'm trying to move the slides of myself and I can't do it. Could you move on to the next one, please?
No bother.
So why is it important to think about pain? Well, a lot of our patients will have pain, but thinking about that, not all of patients who have cancer will experience severe pain. But the vast majority of patients can have their pain well controlled with very basic pain management. So if you were to follow the sort of the guidance, then the vast majority of the patients that we all see could have their pain well controlled. I guess one of the things that's really important to think about is how important it is to take a good history and consider what's causing the pain, to decide what kind of medication you're going to use and what other interventions you're going to use. Sometimes patients have got more than one pain. Sometimes they might have something that's very chronic, or not opioid or not responsive to the kind of medications that we tend to use. So it's really important to get an idea of why you think somebody's sore and tailor your interventions accordingly. Next slide, please. So pain can be divided into different categories, either by its duration. So you can have acute pain, so a new sudden onset pain, or a chronic pain. Or it could be divided into type. So it could be nociceptic, which is when pain is caused by specific injury to the pain receptors. Or it could be neuropathic, so that's nerve ending pain, or visceral, which is from pain from the organs. And all of those different pains have got different characteristics, and we'll go on to discuss that a bit more. So the basic principles of pain management, can you just press the next one? I think this, yeah, for some reason I've got this coming in. Can you press it a couple of times, please? Yep. So it's a really good, it's really, I can't stress the importance of taking a good history enough. And, you know, I think, you know, when we're deciding what to give somebody for pain, it really depends on the story that you get. And that's the basic gist of it for any good symptom management. So the same with nausea and vomiting, the same with cough, the same with pain, the same with any symptom that our patients get. It's really a case of taking the history and trying to work out what you think is going on. And that's really about pattern recognition and about, you know, working out what does it feel like, what helps, what makes it worse, what's the effect of drugs, what's the effect of other things, what do we know about their illness, what do we know about has happened in the past, what do you know, how, and putting that all together. It's really a good idea to get an idea of what the patient thinks and what they're willing to take, what they're willing to do, because often people have got really unusual ideas, or things that you don't even consider that they have got, that they might have a preconceived idea about whether they want to take an opioid or whether they don't want to take morphine for whatever reason, but they'd be happy to take something different. So, you know, getting an idea of that before you start, and using that in part of your plan, so getting the patient on side. It's really important to assess the response to whatever intervention you give. So using things like a simple pain assessment tool to give you an idea of how things were to start with and then how things were after your intervention is really useful. And that's something we use a lot in settings like care homes and hospital, when we're not there to see what's happening, so that we can get an idea of some feedback from people. In terms of the medication, how long does it take to work? That gives you an idea whether, you know, is it maybe not being absorbed if it's taking far too long to work, or is it maybe not the best medication if it's not working at all, and how long does it last? And you think about the path of, you know, how these drugs work, what's the physiology of the drugs, what's the pharmacology, and does it fit? And if it doesn't, why doesn't it fit? Things like we know Oromorph works for approximately 4 hours. If it's not lasting 4 hours, it's either not the right drug or it's not enough. And so we can use those patterns to guide what we do. And the other really important thing is specifically asking about side effects, because patients don't tell you about things, or they put it down to something else, or they just don't take your drugs because they've had nasty side effects. So it's really important to ask and be proactive about treating that. Next slide, please. So thinking of the different kinds of pain, thinking about neuropathic pain in particular, there are certain things that people will say to you about pain that makes you think it's more likely to be due to nerve damage. Patients will describe something where they maybe have reduced or altered sensation. They might describe weird sensations like the feeling of things trickling down their arms or legs, and that's very typical of neuropathic pain. Other specific things that we look for when we're examining or when we're asking patients is the idea of allodynia, which is a reduced, it's an increased painful sensation to something that isn't normally painful. So say, for example, if I had nerve pain in my hand and you were to touch that lightly, that might be perceived as sore or different to how it normally is. That's allodynia. And you often see that around the site of where nerves have been either cut or damaged due to various different things. Hyperalgesia is an exaggerated pain response. So that's where something that is normally sore is really sore. And you'll have all experienced that if you ever had a toothache, where you get that sort of really agony thing that maybe normally isn't as sore, but it's really, really sore. So these are all things that make you think, oh, that's a neuropathic pain. And if it's a neuropathic pain, then it might be more likely to respond to adjuvants in the first instance rather than just opioids, depending on the patient and what the pain's like. Next one, please. So analgesics can be divided into different groups. So we've got opioids, adjuvants, and non-opioids are the main three things. Can I have the next slide, please? Thinking of opioids first, we have weak opioids such as codeine, would be the most common thing that you would see, and stronger ones like morphine. Morphine would be your gold standard first line opioid if you're prescribing for somebody. Can I have the next slide, please? Adjuvants, we're looking at drugs like steroids, antidepressants, and antiepileptics, muscle relaxants, bisphosphonates. Basically, an adjuvant analgesic is something that isn't primarily used for pain, but that we use for pain. Next slide, please. So when you're prescribing medication for pain, after you've done your pain history and decided what you want to use, it's really important to think about the WHO ladder that I'm sure everybody's heard of, where we start at the bottom and work our way up. So the bottom would be a weak opioid, and going up steps to a stronger opioid such as morphine. It's important that if you're got somebody who is already on a weak opioid, you wouldn't add in a different weak opioid, you'd go up the ladder. So you'd go up to something stronger like morphine. Adding weak opioids together is really not beneficial in helping symptoms, and it actually adds to the side effects. So it's not something that we would advocate doing. And it's really just thinking, what's the right medication, what's the right dose, and how often. You wouldn't necessarily have to start at a weak opioid. If somebody has got really severe pain, then you would go in at a higher level of the ladder. So it really just depends. The other thing is, if somebody has got really very neuropathic pain, you might not give an opioid at all. You might use an adjuvant first line. So it's trying to think what's the best thing to do. And also in general, you would use the oral route if you can. Next slide, please. Oh, I think we might have gone back.
Wrong way
Oh. And that's just a schematic drawing of that. So next one, please. Okay, so when you're choosing an opioid, first line would be morphine. Second line would be oxycodone, and third line would be something like hydromorphone, fentanyl, alfentanil, depending on the specific circumstance. So if somebody couldn't tolerate morphine, then oxycodone is a good alternative. It's available orally and subcut. It mixes with most of the other drugs that we use, so it's really useful. Sometimes we would go for oxycodone first line if somebody had renal impairment that wasn't so awful that we would go for alfentanil, but was not good enough that we would be happy to give morphine. Or if they had other specific issues that we wanted to use oxycodone. But it tends to be if somebody's become toxic or morphine wasn't suitable for whatever reason that we would switch to that. Hydromorphone, we use less and less with the use of oxycodone. It's got funny numbers. It's quite difficult to work out the dose, which is why one of the reasons we don't use it so much. Alfentanil is something that we use a lot because it's really useful in renal impairment. It has to be given though in a syringe driver. There isn't an oral preparation that you can use, so that's a disadvantage of it. Fentanyl, you're talking about a patch. Disadvantages of that though are that it takes several days to reach steady state, so it's not good in establishing an analgesia in somebody who's not well controlled already, and it's not good if you're having to up and down the doses because it takes too long. Next slide, please. So the thinking about the equivalencies to morphine, this really just shows how you work out the going from one to another. If you think of morphine as the gold standard and the sort of basic building block, I always go back to that when I'm working out doses. Oxycodone is doubly as strong. So to get the dose of oral oxycodone from the dose of oral morphine, you would divide the total dose by 2 to get the total oxycodone dose. If you're going to, if you're looking at getting a hydromorphone dose, you divide the total morphine dose by 7.5 to get the hydromorphone dose. And if you're looking at for example, codeine, it's you would oh, can't even think straight here. Excuse me. The ratio for potency for weak opioid, so 30 milligrams of, for example, 30 milligrams of codeine would be 3 milligrams of morphine, is what I'm trying to explain, and I can't get my words out. So it's 10 times, you divide it by 10, is what I'm trying to say. So next slide, please. We've probably been through a lot of this already. So morphine would be your first line opioid. It's oral or subcuts. When you're looking at getting a subcut dose, you have the oral dose. Problems of morphine is that basically its metabolites are all active and they accumulate, so you get significant side effects, especially in renal and liver impairment. Opioid side effects are things like drowsiness, hallucinations, peripheral shadows, myoclonic jerking, that kind of thing. Next one, please. So oxycodone is twice as strong as morphine, so you half the dose. And if you're looking at going from, again, if you're going from oral to subcut, you half that dose as well. It's a second line opioid, but we see it more and more. People tend to, it's better in renal impairment than morphine is, but it will still accumulate. So you do get, tends to be drowsiness longer term. And it will also accumulate in liver impairment. So it's not great under those circumstances, but no opioid is good under those circumstances. So it's trying to work out the best of a bad bunch, to be honest. Next one. So fentanyl patches. Fentanyl patches can be a bit of a dirty word because they can be very useful, but equally they can give a lot of side effects and can be tricky. The main problem with them is that they take so long to kick in. So it's fine if you've got well-controlled pain and you know exactly what somebody's on and you're switching them over, say, from a syringe driver to it. That's easily doable. The problem is if somebody has got poorly controlled pain and you slap on a fentanyl patch, it's at what point does that kick in and what do we do in the interim? And then they get side effects and become really, really sleepy and you take it off and it takes 2 days for it to get out their system and they're still drowsy and you can't, whereas if somebody's on oral morphine and they get side effects and you stop the dose, then you stop it. And it's out of your system much quicker because of the different half-life. So, you know, it's really, it's useful because you don't have to swallow it, you don't have to remember to take it. It gets changed every 3 days. It's, you know, it can be useful from that point of view, but it's not without its own thing. The other thing to think about is if the amount that you absorb varies depending on how fat you are, on how hot you are as well. If you're hot, you absorb more. So it can be quite variable, and the patches sometimes don't stick that well. If you're hot and sweaty, so or if you're too skinny, they can kind of not stick all that well. So it's they can be a bit tricky. Good thing with them is though that they're not fentanyl's not you don't need good renal function, so it doesn't, if you're somebody who's on dialysis or you're somebody who has renal failure for whatever cause, it's really useful in those circumstances. In toxicity from fentanyl patches, you tend to become increasingly sleepy rather than have the other normal side effects. So you don't tend to get jerky in the same way. It tends to be a sleepiness. So it's just bearing that in mind and keeping an eye out for that. That's next one, please. So alfentanil, you know, about 10 years ago, you wouldn't have seen it used that much. Now it's really, really commonly seen in hospital, in the community, in the hospices as well. It's a potent opioid. It has really rapid onset and a short duration. So we use it, it's useful for instant pain or for if somebody's having care and needing some analgesia for that, it can be useful for that as well. It's really useful in people with renal failure. That's where it really comes in more than anything. And it is it's 30 times stronger than oral morphine. So the way that you would think about it is if you work out your diamorphine dose, which would be 1/3 of oral morphine dose, then you divide that by 10 again to get the alfentanil dose. So it's just always being very aware that it's very, very strong and that the doses should be small. I've had a few patients recently on really big doses, and I had to speak to it was somebody in the community actually, I had to speak to the GP to say, look, this isn't a normal dose for alfentanil at all. And I think because it's unfamiliar, people don't realise, and they don't necessarily realise that that's not that we would expect it to be 0.5 of a milligram would be fine, or 1 milligram would be fine. It's not like the starting dose of normally diamorphine, you would expect 10 maybe, roughly, whereas 0.1 would be the equivalent of that. So it's thinking about and always trying to work out what it is. When I do alfentanil conversions, I do it on a bit of paper, and I go back to oral morphine first, and then I work it out. And I almost always do it with somebody else as well and get them to do it separately, and we check, just because there is that big error, margin for error, and you don't want to accidentally work out the wrong dose, because it's very easy to go the wrong way in one of the calculations and get it wrong. So I would always advise to get a bit of paper out and a pen and write it out. The other thing to note with alfentanil is not to confuse it with fentanyl, and fentanyl is even more potent. It's 4 times more potent than alfentanil. So, it's been very aware these are different drugs and they have different indications and different strengths. We also can use alfentanil as a sublingual spray, and you can actually use the vial for injection sublingually if needs be as well. It's not very nice, but it's something that you could use in certain circumstances. Next one, please. So titrating opioids. I think there's probably a few more actually. Yeah. I don't know how I've managed to do that in some of the slides. That's great. So there's basically start low and work up, and reassess the pain, reassess the side effects, look for specific things, ask about peripheral shadows particularly. When you're starting an opioid, if they've never been on an opioid before, then it's likely that they'll feel nauseated. Most people do feel nauseated to start with, and I would give them an antiemetic along with it to start with if they're opioid naive. So something like metoclopramide would be useful, because the physiology behind the nausea related to opioids is that you get gastric stasis. And that if you give some metoclopramide, it helps move that on and helps with that as well. Anticipate that when you start an opioid, people are going to get constipated. The vast majority of people do. If you're young, mobile, lots of good intake, then you might not be constipated, but most people will require a laxative. So either you can start on something long acting straight away, or the gold standard though is to start on a short acting every 4 hours regularly, plus as required, work out what they need, and then divide it by 2 and give morning and night. And you can use any long acting preparation. The GG&C, now it's Zomorph that is the preferred option, but you can go for MST, you can go for what else is there? I can't even think. But anyway, you can go for whatever, or you can go for MXL, which is a once a day preparation, but it's very rarely used. The normal thing would be to go for Zomorph or MST. Next one, please. So in some circumstances, patients aren't able to tell you that they need, for whatever reason, they're not keen to ask for breakthrough, or they might be they might be put off for whatever reason, or not be able to access it. So in those situations, if they're still sore, it'd be worth increasing by about 1/3, and reassessing. Really, the only kind of reason that we get a ceiling dose isn't about the actual dose, it's about the side effects, and whether it's effective or not. So if they're still sore and it's working and they've not got side effects, then you can push the dose up. Next one, please. So breakthrough, I've noticed more recently with electronic prescribing, there's a lot of people who seem to think that they could only take their breakthrough every 4 hours, but it can be repeated every hour. And if they're having to take it every 4 hours all the time, then we're obviously needing to look at the dose. But if they're still sore after they've taken their breakthrough, I would repeat it in an hour to see if it's actually effective or not, and then maybe look at increasing things after that. So a sixth of the total 24-hour dose over as required hourly, up to, I tend to put a maximum of 6 a day, just because you would want to reassess the doses, because if you're needing a lot, then we need to look at increasing the doses generally. Next one, please. Has anybody got anything they want to ask about opioids before we go on to adjuvants? Can I just crack on?
I think there's anybody got any hands up or anything yet, Lindsay? No.
Okay.
Thank you.
Okay, so first of all, thinking about things like gabapentinoids, so gabapentin and pregabalin. These are drugs that are presynaptic calcium channel blockers, and they bind to receptors that are upregulated in neuropathic pain. They have very similar side effects, and the rules for both of them is you start low and work up. Both need to be reduced dose in renal impairment, and both are Schedule 3 controlled substances. So you need to have controlled drug requirements for them as well. Next one, please. So gabapentin, start at 100 milligrams 3 times a day would be a reasonable starting dose. Sometimes though, if somebody's really frail and elderly, I would go for just 100 at night, and then work up quite quickly to 3 times a day, but just to see how they get on with it. And basically you titrate it according to response, up to a maximum dose of 600 milligrams in 24 hours. But if you're getting towards that, then you're kind of wondering whether it's the right drug. Side effects tend to be drowsiness, jerkiness, and kind of almost like a dyspraxia, but it can make people feel really, really tired. In chronic pain, patients have weight gain and increased appetite. I've never noticed that in any of my patients. They do tend to get, some people get edematous with it, but I've never really noticed the other things as side effects as such. Pregabalin, it's a much smaller dose, and the advantage is instead of a 3 times or 4 times a day schedule, it's just twice a day. And start at 25 twice a day, increasing up to a maximum of 300 twice a day. Disadvantage of that is it can prolong your QT interval, so you have to think about interactions with other drugs that do the same. Next one, please. So sometimes we switch from one gabapentinoid to another if we're not winning with pain control. And as a general rule, gabapentin 300 3 times a day, you would switch to pregabalin 100 twice a day. If you were on much bigger doses, then you could go for 200 twice a day and then work it up. And it really is still the maximum dose is 300 twice a day of pregabalin. Next one, please. So other drugs that we use for as adjuvants, amitriptyline is a useful drug, but it's a dirty drug. It has a lot more side effects in terms of drowsiness, dry mouth, confusion. It can cause urinary symptoms as well. It also has fairly significant cardiac contraindications, and it can prolong your QT as well. It's useful though if somebody maybe has worse pain at night time and it helps them sleep. And again, we use really small doses, start slow and push it up. So 10 milligrams at night would be a normal starting dose, and then pushing that up, but rarely having to go any more than 100 milligrams at night time for that. Next one, please. So steroids as an adjuvant, they can be really useful if you have got tumour edema that you think is causing the pain. Also can be useful in specific circumstances. So if somebody has got pain secondary to a cord compression, for example, we would use steroids for both those purposes. Or if they've got headaches secondary to brain metastasis, we would use it for both those things as well, for the pressure and for the pain. It can also help other symptoms such as nausea and vomiting that are associated with that pathophysiology that's going on. Depending on what the issues are, depends what dose you would use. So if you've got raised intracranial pressure, 8 milligrams to 16 milligrams would be the dose for that. If it's liver capsule pain or neuropathic pain, both of which respond really nicely to steroids, you'd go for a smaller dose and just 4 to 8 milligrams. And basically you want to make sure you give that in the morning. You think about a PPI, you monitor their blood glucose and you reduce it to the lowest effective dose. Now, sometimes that means coming down, symptoms getting worse and going back up again. It's also useful to stimulate other things like stimulate appetite and well-being as well. Next one, please. Anti-inflammatories, so things like ibuprofen, Voltarol, that kind of thing, really useful for body type pain, also useful for liver pain and other soft tissue infiltration or inflammatory type pain. But risks of GI ulceration or bleeding are high with these drugs, and it's just continually kind of weighing up the pros and cons of giving these drugs. You have to watch with renal impairment because non-steroidals will affect your renal function. The other drugs, so things like morphine, they're affected by your renal function. So say your renal function wasn't as good, morphine won't make your renal function worse, but it will accumulate and you will get side effects. Whereas an anti-inflammatory, if you take it and you've got renal impairment, it will make your renal function worse. So that's doubly as risky, and you will get side effects as well. But the main issue is that it will make your renal function worse, then might make you not tolerate your opioid or might make you not tolerate other drugs. So it's considering all those interactions and how all that works together. Non-steroidals can cause fluid retention and you can have adverse cardiac events as well. So they're used less often as they used to be, but in certain circumstances it can be really useful. You can also give non-steroidals subcutaneously in a pump as well, whereas things like, and you can do that with the dexamethasone, but you can't do that with gabapentin. There isn't an option for giving that in a non-oral route. So these things will also play on your choice of drugs. Next one, please. So other things that we can use for pain control: TENS, radiotherapy, bisphosphonates, muscle relaxants. So Buscopan can be really useful as well for bowel type pain. Ketamine, clonazepam, also, all very, very useful and have their place as well. Advantage with clonazepam is it can be given subcut as well, and can help sleeping at night time. And ketamine again can be given subcut in an infusion too. So these things have their place as well. Next one, please.
I think that's us on our case.
That's us on to the case studies. Yep.
Just going to stop sharing. Is that okay?
Yeah. That's brilliant. Thank you.
It's a bit of a dry subject, so I do apologise, but hopefully the descriptions and the options that you have there will help with the case studies and help sort of bring it together and make it a bit more interesting with the case studies. Does anybody want to ask something before we go, or any comments? If I've said anything weird that you weren't expecting? Maybe everybody's falling asleep.
No, Laura.
So sorry, Lindsay, I'm quite new to palliative medicine, and you mentioned something just at the end there about NSAIDs, and did you say you can give them via pump? I was just wondering, for me, that's just a new concept. I just wondering what agents you use and kind of what your threshold would be for giving them.
So you can use things like ketorolac. You can also give diclofenac as well, and you can give diclofenac as a bolus if needs be. You can give diclofenac rectally if you have to as well, so that's another way to administer that too. But yeah, it's not something I've actually used in a while. We used to do it a lot, but if somebody has difficult pain that you're not getting on top of with other things, but it's particularly inflammatory, then you might use it at that point, especially towards the end of life if you're struggling. You would get the details about, I'm sure it'll be, if it's not in the guidelines, you definitely find it all in the PCF about how to do that, and also on the forum on the palliative drugs. They have lots of discussions about how to give it, because it's not necessarily licensed how we do it.
Typical palliative care.
Yeah.
Thanks, Laura. Thank you.
Thanks for asking.
Anybody else get anything for Lindsay before we move into the groups?
James raising her hand. No?
Jane? No, she's maybe just waving to you.
I thought you had a comment. No?
Okay, what we'll do is there's a couple of slides. We'll put you into, I think we'll put you into three breakout rooms. Jackie's going to do that. So you'll automatically disappear into small breakout rooms, probably of about five or six. And what we'll do is we'll share a slide. There's two slides for this case study with a few questions. So we'll share the first slide, give you about five or so minutes to kind of think about it, jot things down, and then we'll share the second slide so that you can, there's another couple of questions in that, and then we'll bring you back into the big group. So maybe when you're answering the questions, just decide amongst yourselves who it is that wants to feedback, and Lindsay will lead the discussion round about that, and hopefully it will generate a bit of questions as well. Is that okay? You okay with that, Jackie?
Yeah, I've got it. You just tell me when to start.
No, just any time.
Okay.
Just any time.
Does yourself and Lindsay want to go into a separate room?
We'll maybe pop in and out, so
okay.
we'll just stay in the big room, but pop in and out. Just
Okay.
remember when you're leaving the breakout room, just click the leave breakout room button, don't click the leave meeting. If you click the red leave meeting one, then you'll disappear altogether, and we don't quite want that. So just press the button to leave the breakout room.
Okay.
I've probably panicked you all now, haven't I? If you leave, we'll let you back in, don't worry.
There we go.
There we
Okay.
go.
So the first case that we're looking at is a 59-year-old lady with metastatic colorectal cancer and retroperitoneal lymphadenopathy and liver metastases. She was a lady that I was looking after last year. She had increasing abdominal pain, and she phoned up looking for some advice because she had worsening pain. she had been started on Zomorph 40 twice a day and was using 10 milligrams as required 4 times daily. So just thinking about what we discussed before, how would you assess her and what would you suggest, and what adjuvant could be useful for her? Who wants to feed back? Who is group 1 and wants to feed back from group 1?
Don't know that we were told what group numbers were here.
All right, okay.
I believe my group, it was somebody from the W.
We were in group
Yeah, that
one,
was us.
yeah.
Yeah.
And so we had said that, first of all, we would take a kind of history from her. Can you hear me okay, actually? I should check.
Yeah.
So we would take a kind of history of what type her pain was, if she was getting good effect in between the kind of 4 times extra that she was taking, how long it was kind of lasting. We said that what we would do is, because she was taking an extra 40 PRN, it would mean we'd increase her Zomorph from 40 up to 60 BD, and we'd increase her breakthrough dose from 10 up to 20. With regards to an adjuvant, we had said, or we would also check if our bowels were moving by, we would ask her about her bowels. We had said that as an adjuvant, we would maybe consider buscopan or possibly the use of dexamethasone in case, because she's got liver mets as well, in case there was some liver capsular pain as well. But that was our suggestions there.
Fantastic. Anybody, group 2, anything else you want to add?
No.
Who's group 2?
Sorry, were we group 2? I don't know. I didn't see the name of the
I
group.
don't know.
Oh, your group, if you go for it, Jane.
Right. Okay. So obviously exact same as Carolyn there saying about asking about if it worked and asking about the bowels and things like that. But the other things that we considered, we went straight with kind of Dex, 8 milligrams, thinking about that, but thinking about checking bloods in case her renal function was off, and thinking about total pain as well. Was kind of just the other things that we thought. We didn't instantly increase the Zomorph because we were kind of thinking that doing one thing at a time. So if you increase the Zomorph and add the Dex, which one's working? So we didn't increase the Zomorph at that point, adding an adjuvant in.
Yep. And all of that's, just as relevant as the other. And I think that's one of the things to say today is that there's not a right answer and a wrong answer. It's just, trying to work out what you think is the best thing at the time. And you're right, I totally agree, doing one thing at a time, so that you know what helps and what doesn't help. That's, yeah. Group 3, I don't know who was group 3, whether there's anything else you would add rather.
Jane, were you in a group? You need to. I think you're muted, Jane.
I suppose our group were just thinking, asking lots of questions. Abdominal pain could mean anything. Is she constipated? Is there something going on in the urine? Is it liver pain we're talking about, or is it a colon pain? Which might direct what adjuvant we would use. So I think it's quite difficult sometimes to tease these things out when somebody's kind of calling in for advice. And we were saying, if you don't see the person, that makes it a wee bit more difficult.
It does. And in this situation, what actually happened was she called in for advice and spoke to one of my colleagues, and her opioid went up. And then she came in, and when I examined her, she had a massive tender liver, and that was what was causing her pain. And we used dexamethasone. The dexamethasone didn't help her at all. It didn't help in the slightest. So we ended up using the opioid in the end. So it's one of these things where you think, haha, I know what it is and I'm going to do this. And it didn't work. Yeah, it's just one of those, you win some, you lose some, I guess.
As you said, Lindsay, it's always going back and asking, did it help?
Okay, we'll move on to the next slide, Jackie, please.
Yeah. Do you want this one, the next one?
Yeah, but, no, just the second part. Yeah, that's the right one. Sorry. Yeah. I think there's just a few other questions there, Lindsay, at the bottom.
Okay, I'm just looking to see. I think we must have missed this. I don't know what's happened, but we seem to have. So she became toxic. We kind of missed that. I don't know what's happened with the slides, but she became toxic, and so we wanted to switch her opioid. What alternative opioid would you go for? And about resources, does anybody know what resources they would use? Or
is that group 1 to answer again?
Yeah, that's fine. How you go for it?
Okay, so we said that we would rotate her to oxycodone, and we would, because it's twice as strong, we would reduce her to, or initially reduce to 30 BD, because we're changing her from Zomorph to oxycodone, we would reduce again by another third. So it would be 20 BD. And we said the kind of resources available to us would be the palliative care guidelines, the BNF, the medics and pharmacist.
Yeah, brilliant. And the other resource that's useful is the palliative care formulary as well. But yeah, the palliative care guidelines really has got any information you ever want to know. I think if she's toxic and you're switching her, you're right, I would reduce the dose as well. If she's not toxic, but it's just not working and she's still sore, then you might just go for the equivalent dose. But as a general rule, you're right, you would work out the equivalent and then cut it back a bit. And a third's absolutely reasonable.
And Eileen had told us as well that would be just if it was the 60 BD and she wasn't using any PRN, but if she was using PRN on top of that, we would include that in the total amount as well.
Yeah.
Good point.
Perfect. Anybody else got anything else they want to add to that?
What about Jane, Jackie's group? Anything from you guys?
I think that's, you know, what we had kind of said, but obviously we're presuming she's able to swallow her medication and we're not worrying about obstruction or anything like that.
Absorption,
absorption.
Yeah. Great. And June's group. Sorry, I'm just giving the group's names. Group 3. June, picking in you, sorry.
I think we just kind of said the same, you know, just reduce it by a third and watch for toxicity. Remember, reduce the breakthrough as well.
Yeah.
Sometimes that gets forgotten.
Point.
Thank you.
Okay, so we've got one more case to go through, but we're not going to go out to rooms this time, just to sort of save a wee bit of time. So this is an elderly gentleman. Are you able to go to the next slide?
The next slide, Jackie.
Yeah.
Thank you. So this is an elderly gentleman who has got metastatic prostate cancer. He lives at home alone. He's got bone metastases and a recent AKI from urinary retention, and he went into hospital and got catheterized, and that improved. He then fell and fractured his neck of femur, and there was some uncertainty as to whether that was pathological or not, but probably pathological. But he also had chronic back pain, and he was taking Zomorph 20 twice a day and some paracetamol. And they became quite unsettled at the end of the week. Zomorph was increased to 25 twice a day, and then up to 30. and he became more agitated and disorientated and was struggling to swallow. And he was reviewed by an out of hours GP, and a syringe driver was started with morphine 30 over 24 hours with in a syringe driver with some breakthrough 10 milligrams of morphine subcut. And he used 6 lots of breakthrough, was really unsettled, seemed muddled. The syringe driver was increased to 80 of morphine, and midazolam was added at 10. And he was bedbound, agitated, hallucinating, and distressed. Is there a next slide there?
The next one.
Yeah, come over.
So, how would you assess him? What do you think's going on? How would you manage? So thoughts first of all. Just what do we all what do we reckon?
Post surgery and post UTI.
Assess his renal function first.
Might be hypercalcemic.
Yep.
Is he toxic? Toxic.
Yep. Yep, all of these things. I think that's basically what went through my mind when I went to see him. You know, first of all, he was obviously very, very toxic when I went out. And you know, it's whether is there something underlying that? So you're right, Ellen. You know, is it that his renal function's gone off again? Actually, his renal function was okay. Surprisingly okay, but you know, was there an infection? Was there something else that precipitated it? Was he hypercalcemic? Somebody else said as well. So these are all things that we looked at. How would you manage those symptoms? So he's toxic, but he's hallucinating, he's agitated, and he's taken to his bed.
Describe something for the agitation. Fluids, give him fluids to rehydrate him.
Yeah. So this was a man who he was at home and he wanted to stay at home.
Oh, he was at home. I thought he was at the hospital.
No, so he was at home. So fluids would have been a useful thing to be able to do, but he wasn't going anywhere. Absolutely, in no circumstances was he going anywhere. And we can do fluids at home sometimes, but it's not often that you would manage to do that. But we managed to get some blood off him to check for his calcium and his U's and E's. So we did that, and his calcium actually was normal. So he was opioid toxic, hallucinating, and agitated.
Jane and Jackie have got their hands up. Lindsay.
Oh, we were wondering, obviously we would be rotating his opioid, but giving him something to manage the agitation and the delirium, something maybe like haloperidol or something like that.
Yep. That's exactly what we used some haloperidol and switched his opioid and reduced the dose. His pain was mainly, once you got a coherent history from him, his pain was his lower back pain that he'd had for years since being in an accident. And it was more positional than anything else. We actually put a lidocaine patch on his back, which helped that pain as well. Anything else we could have done for his pain, if it was musculoskeletal pain, is anything else that anybody might have?
What about putting in a steroid, as in another driver up with the likes of I can't remember the name of it. Diclofenac? No.
So an anti-inflammatory. Yep, you absolutely. And sometimes even just using the topical anti-inflammatory can be useful, and give the family something to do as well, which can be useful. Or heat pads, or I don't think he wouldn't have managed a TENS regime, but that kind of thing can also help with musculoskeletal pain. So, but heat pads can be really useful for that sort of thing. He had been stuck on a chair, so trying to get him into a proper bed and making sure that he was comfortable in the proper bed made a difference as well. Switching his opioid, what would we go for? Anybody else want to chip in?
I can't remember what he was on.
I think he was on Zomor. No, morphine. He was in a syringe driver with about 80 milligrams of morphine.
Large dose. Change it to oxycodone if his functions were okay.
Yeah. And but in that circumstance, it's hard because you think, well, what dose do I go for? Because it had been cranked up so quickly that, what had really been happening, I think, was that opioid toxicity was being treated with opioids. So he was getting side effects and agitated, and therefore being given opioids, which was making him sleep and then making him agitated, and then he was getting more opioids. So trying to work out what on earth dose to go for, that's where it's really tricky. I went for quite a small dose of oxycodone, somewhere around the 25 milligram BD dose of Zomorph that he was on at the sort of beginning, as things were just increased a wee bit, because that's when he was most well. But it's really, really hard to know what to do. And sometimes it's you go with your gut instinct and you review the next day and see. And yeah, it can be quite tricky. But as a rule, if somebody's really toxic, working out the equivalent dose and then reducing it by at least a third to a half if they're as toxic as that would be a reasonable thing to do. And as you say, managing the toxicity with either haloperidol, or you can use levomepromazine, which is useful if somebody has been quite agitated and you're needing them to settle. That's useful for that as well. And, as somebody else said before, things like fluids, even just pushing, if they'll manage to drink oral fluids, is really useful too. And for him, adjuvants, we spoke about that already, about different options as well for, the patches and heat pumps and heat pads and that kind of thing as well, which can be really useful. He woke up and was walking around the room with carers within a day, and is still going strong months later. Much to his family's delight, because I think they thought, my goodness, he's got metastatic cancer, this is him dying. So they were all really distressed, and I think that's what they all thought was going to happen, but he's done really, really well, which is nice.
That's good. Thanks, Lindsay. Thanks, Lindsay.
Anybody?
Yeah, that's what I was going to say. Does anybody have any other outstanding questions for Lindsay, or really difficult questions for Lindsay? She's really good. She's good at answering really tricky questions.
You're really funny, aren't you, Susan?
We're so cruel, Lindsay, that's what we are.
Well, there's Alistair now as well. Alistair will answer the tricky questions. He's even better at answering tricky questions.
Oh, is that okay for everyone? Okay.
See you later.
Thanks very much, Lindsay.
See you later.
See you later.
Thank you. So welcome everyone back to our last presentation of the day. So thank you very much to Dr. Alistair McEwen for agreeing to do this. And Alistair's title today is Subcut Fluids, Evidence and Practice. So he's going to chat us through that module. So thanks very much for that, Alistair. Over to you.
No problem. Can everyone hear me okay?
Yes.
Good. And can everyone see the slides?
Yes.
Good. Okay. So what I was overhearing there was this has been a slog and you're all exhausted and you're looking forward to a brief presentation. Is that right? We'll see what we can do. So Fiona and Jackie asked me to take this session, and I think it's being recorded as well. A couple of things to say. One, we're not going to take the full half hour, so there's ample time for discussion. Two, these aren't my slides, but we can talk about them as we go through and find areas that stimulate different discussion if needs be. And three, I can't pronounce hypodermoclysis consistently, so we're just going to call it subcutaneous fluids on a regular basis from here. Subcut fluids, as you guys will all know on a regular basis, are a really difficult area, fluids in general. And whenever I'm speaking with patients and families about eating and drinking and fluids, I'm always aware of how fundamental an aspect of care it is, because everyone remembers from when they were kids being unwell, their mum bringing them soup, people making them drink cordial if they've been unwell. And it's one of the last things that families and loved ones can often provide. So when they're seeing somebody struggling with reduced oral intake, becoming more dehydrated, eating and drinking less, which we are all used to as part of managing patients with advanced disease towards end of life, it can be a really difficult emotional area. And having some understanding of what the best possible evidence is and how you can manage that in different ways is really important. In terms of subcutaneous fluids, they were really mentioned first in about 1865 as part of the cholera outbreaks. Now, interestingly, when you're looking at intravenous fluids as well and intravenous therapies, they sort of emerge at a fairly similar time, around the time of those cholera outbreaks, because people were looking at different ways of managing situations, of getting medications and fluids into individuals. From the point of view of subcut fluids, it was Arnaldo Catani who described this using of a thin trocar inserted underneath the skin, fitted to an elastic tube, and then dripping fluids underneath under just the pressure of the height. In terms of IV therapies, they were beginning to be used around the same time, but as a result of complications with infection and injecting non-sterilized products into your intravenous spaces is generally not considered to be a great idea. And subcut fluids were widely accepted as a route for hydration in the 1940s and the 1950s, but then because of problems with adverse reactions, infections, and possibly the use of the wrong types of fluids, they kind of fell out of favor. They have gradually crept back in again with ease of use. And there has been some research certainly demonstrating that it can be done without significant side effects and without harm, although the evidence of efficacy and benefit is somewhat more lacking. But as a result of those abilities to do that, subcut fluids have been more frequently used. And in general, it's care of the elderly and palliative care type approach rather than other specialties. And certainly I can remember working in care of the elderly units as a baby doctor, and subcut fluids being something that was used on a regular basis, and that's an increasingly long time ago now. In terms of evidence, anyone who has looked up the evidence for most things in palliative care will have found that the sentences, "there are insufficient good quality studies to inform definitive recommendations," is a really common one. And there is a Cochrane review, which I think was around 2014, maybe a little bit later, looking at a review of RCTs to see if there was any benefits or evidence base to build on there. Now, there are quite a few other studies actually looking at fluids in palliative care and end-of-life patients, but in terms of randomized control trials and those gold standard approaches, they are pretty limited. They, I think, identified 3 RCTs, and as I said before, insufficient good quality studies to inform definitive recommendations. None of those RCTs address the specific issues of the routine use of clinical assisted hydration at end of life and until death. And there was various other criticisms that the Cochrane review leveled at these, including the fact that the volume of fluid that was being supplied was not sufficient to reverse dehydration. These patients were often starting from a point of dehydration, and a number of other problems as well. So that doesn't really help you at all. In terms of thinking from first principles, what are the potential pros and cons of subcutaneous fluids? So in general, people think about managing patient comfort. So issues with thirst and dry mouth, and making sure there's adequate nutrition and oral care to maintain and prevent those symptoms. Obviously, again, we're aware that a lot of the medications we prescribe can worsen dry mouth, that oxygen and breathing as someone becomes more frail can cause problems with dry mouth, and it's not always just down to hydration as a main issue. But the other things that absolutely make sense is that as people eat and drink less, their renal function is likely to deteriorate, and an accumulation of metabolites, an accumulation of medications can contribute to delirium, hyper and hypoactive delirium. But as we said before, there's little evidence to actually support that clinically assisted hydration can help with any of these things. The potential negatives, which again make sense from first principles about starting someone on clinically assisted hydration, include fluid overload, especially those patients who already often have peripheral edema, low albumin, or cardiac failure, and increased fluid-related problems such as nausea and vomiting or respiratory secretions towards end of life. But again, the evidence for these negative effects as a result of clinically assisted hydration simply isn't there either. The question again, and within palliative care research and palliative care, people are often very precious about this patient group, which is interesting because actually any study that's ever looked at palliative care patients wishes to be involved in research has shown a real appetite to do that even when people are frail. But there is difficulties in getting past ethics groups sometimes, and actually constructing studies that are reliable and repeatable. There was a study by a very big name in palliative care called Bruera, who compared hydration with placebo. So it was, I think, 1 liter to 1.5 liters of subcut fluids versus placebo, which was a bag with 100 mils of fluids. And he demonstrated that there was no obvious overall difference in survival, objective evidence of symptom benefit, or improvement in quality of life. However, they did undertake some qualitative studies with the same group of patients and the families, and that suggested that there was a perception of enhanced quality of life and comfort. More recently, and this is where things might get a little bit more interesting over the next couple of years, Andrew Davies, who's a palliative care consultant from down south, completed a trial called Chelsea, which managed to design and undertake a randomized controlled trial in a cluster basis, so individual units of 100 patients, I think, looking at fluids for patients who are actively approaching end of life in hospice settings. And whilst the numbers were small, there were some potentially favorable outcomes. Now, the headlines that came out out of this study, having Googled it fairly recently, were patients given fluids at end of life will live longer. The potential extension suggested by this study was about 1.5 days. So we weren't talking about long periods of time. But there was also potentially some reduction in agitation and delirium towards end of life, which again could potentially be quite an important finding. And to follow on from that, there is currently plans for the Chelsea 2 trial, which multiple hospices across the UK have been asked to be involved with, including the Prince and Princess of Wales Hospice and some other units in Scotland as well, I'm sure, looking to repeat that work on a much bigger scale. And they're hoping to actually start with data collection and patient recruitment towards the end of this year. So again, there may be some more robust evidence to help guide us in the not too distant future. So, given the complete current lack of evidence to support the use of subcut fluids at end of life, the GMC basically says, take it on a case-by-case basis, which I think is probably what most of us do anyway. It will vary very much depending on the patient, the individual clinical situation, the comfort, the individual symptoms, the patient preferences, and often family preferences as well, because they are often the ones who are more distressed by a reduction in fluid intake than the patients themselves. So Scottish Palliative Care Guidelines has a section on this, and hopefully you can see that this is a fairly busy flow chart, but it gives you a straightforward decision-making process to work your way through for anyone that you're considering giving fluids to. So we'll just take it through from the beginning. So at the top, any patient that has been considered for subcutaneous fluids. Does the patient have signs or symptoms of reversible medical conditions that may benefit from parenteral hydration? If the answer is no, then the patient doesn't need subcut fluids, and it's about discussing with the patient and family as appropriate. If it's yes, then does the potential benefit from these treatments outweigh any burdens? And I suppose in this type of situation, I'd be thinking often about patients who are either already fluid overloaded or patients who've got significant agitation. And that's often one of the most difficult things, where you don't really want to be sticking something else into the person who's already wriggling around the bed or uncomfortable or feeling like there's too much in the way of interventions. But there can be a number of other things that may be considered burdensome. So if the burdens outweigh the benefits, again, not for subcutaneous fluids, discuss with the patient and the family as appropriate. Then, if the potential benefits outweigh the burdens, does the patient have severe dehydration or require emergency rehydration? If the answer is yes, subcutaneous fluids are not best placed for aggressive fluid rehydration. You can get 1.5 liters or so into someone if you're pushing things reasonably firmly, which may not be enough to reverse severe dehydration. You may help a little bit in terms of biochemical measurements of hydration, but if someone needs proper volume of fluids, then IV is the way to go if that, again, is appropriate. Again, all of these decisions are not completely black and white, and there'll be grey areas to consider and discuss within that as well. If the answer to does the patient have severe dehydration is still no, and they may benefit from all of the above, and the benefit's going to outweigh the burden, do they have signs or symptoms of fluid overload? Now, that can be really tricky in patients who are frail, deteriorating, bedbound, low albumin, because whilst they might have a lot of peripheral edema, they can still be intravascularly deplete and have renal failure as a result of that, or have symptoms of being clinically dehydrated despite the fact that their legs are swollen up. So that can be really tough to make that assessment, and you may need assistance from medical colleagues or just some straightforward discussion with family about the difficult nature of the situation. If there's no signs of symptoms of fluid overload, then a trial of subcutaneous fluids can be considered. Now, I think the key thing whenever you are thinking about a trial of subcutaneous fluids is that it should be time limited. There needs to be a clear discussion with the family that we're going to give this a go for whatever you think is appropriate, 24, 48 hours. And if there is no clear benefit, no improvement in symptoms, or obvious worsening of side effects or issues with that, then they're going to need to stop. And making sure patients and family are aware of that is of paramount importance, and usually pretty well received. I think people often feel like they just want you to make sure you're trying everything that you can be trying in the appropriate situation. The guidance is also laid out a little bit more fully in the Scottish Palliative Care Guidelines. Now, as I mentioned, I didn't write these slides. I did, however, write the guidance in the Scottish Palliative Care Guidelines. So I'm glad to see that whoever wrote the slides deemed it as good as any. That's nice to know. It gives you some clear instructions about how a line should be sited with aseptic technique, the types of fluids that can be used. Now, there is a little bit of variation in practice. Essentially, you want something a little bit salty because that will hopefully avoid stinging. One thing that's often asked about is, can you put potassium in these fluids? So again, I did a little bit of reading around that, and the answer is probably, but not very much. So again, on a case-by-case basis and looking at the evidence of what's going to be beneficial. Generally, you're not looking at big volumes of fluid here. As I say, 500 mils, 8 to 12 hourly. So you might get 1.5 liters in. There is in the literature larger volumes being pushed in, but you have the risk of more in the way of discomfort or problems, I guess, with that. The infusion site should be under daily review for signs of infection, fluid accumulation, or discomfort. And certainly my perception is often localized pooling of fluids is far and away the most common problem causing discomfort, or a patient becoming too agitated and distressed by having an extra tube put into them. Patients should be under daily review for fluid accumulation or overload, and patient should also be under daily review for the benefits and review of future prescribing. So as we talked before, setting those boundaries at the start, being clear that if there is no benefit or there is excess burden, we're going to be stopping and taking it on a day-by-day basis. Interestingly, these guidelines did go out to external review, and whilst they were broadly very accepted, there were some people who felt that the evidence base was too poor to be able to be putting in place the recommendations that we had done. So it remains contentious even when you're trying to be as general as possible. The other guidelines that are available, I believe these are the Accord Hospice Clinically Assisted Hydration in the Last Few Days of Life policy, which again provides some guidance, clear overview of the pertinent issues surrounding clinically assisted hydration, as well as Accord's procedure for subcutaneous fluid administration, which basically says good quality care is really important. So patients should be supported to give oral fluids. Good quality mouth care and oral care is really important, management of thrush, other means of managing dry mouth, such as oral gels, mouthwashes, or other artificial salivas may be of some benefit, but clinically assisted hydration should be considered when patients are struggling to maintain their hydration due to increasing frailty. The balance between burdens and benefits of clinically assisted hydration should be determined on an individual basis. So all the way back to what the GMC were saying at the start, which is it's a case-by-case decision, manage everything that you possibly can, and fluids are potentially worth a go, but you have to weigh up the benefits and the burdens of that. And there is alternative routes as well. So proctolysis and PR intervention absolutely can be a means of getting fluids into people. I think Gillian McKeith is the advocate of the coffee enema, and there's all sorts of stories about alcohol being administered via this route as well, often in relation to rugby teams, I believe. So alcohol can also be very well absorbed that direction too. So subcut fluids, contentious at times, sometimes worth a go, and the evidence base, whilst at present is pretty patchy, there are some robust RCTs currently in development and hopefully producing some evidence over the course of the next couple of years. And that is all of the slides.
Thank you very much, Master. Let's stop sharing that. Thank you for that. That's a very interesting overview. And you kept my attention, so that was very good at the end of the day. And I can see everybody else looks very awake, so you've done a broad job of keeping us all engaged at the end of a very busy day. So thank you. I'm just going to go out to the group because you raised some really interesting points and thoughts, and pause for reflections just to check in with everybody. Does anybody have any questions for Alistair? Jackie and Jane.
Thanks for that, Alistair. I had never seen the Scottish Palliative Guidelines, the flow, so I'm so sorry about that when you wrote them. Sorry. But I'm looking through the kind of pocketbook and it's not in that. Is it just on the online and in the big folder?
Yes, clearly. I don't know the answer to that. I didn't know it wasn't in the pocketbook.
I can't see it. No, just in the big one. Okay, thank you.
I also, you know, when I was listening to you there, just thinking, oh my goodness, you know, absolutely for an inpatient unit patients, you know, the trial, but see the furore that would cause in the community if patients were getting it in the IPU and then we couldn't support them in the community with them, because we get asked frequently, and it's just as you say, you know, patients' family want to, you know, cover all bases and make sure no stone is unturned in the patient comfort. And I think it's really difficult because sort of reading through the evidence, it's not strongly one way or the other. And so they say, well, just try it. So I think it is something that really absolutely needs a lot of research.
Yeah, and if the RCT then comes up saying fluids help with symptom control and reduce delirium at end of life, then absolutely you'd have a benefit for pushing it. There is an NHS GGC SOP for provision of subcutaneous fluids in a home or homely setting. But I have never seen it practically applied, and I'm certainly not sure that right now is the time to start saying to district nurses, can you crack on with this?
No.
But in theory, there's a document there that would support it.
Okay. I think maybe about 20 years ago in district nursing in Paisley, we did have a very few patients that we tried, but just absolutely couldn't maintain them. Yeah. Because at that time the out of hours were, you know, that was even less than it is now. I don't even know if there was a 24-hour service. So it's just supporting patients in the community. It just would not be possible.
Yeah.
No.
Thank you for that, Jackie and Jane. Any other questions from our lovely audience for Alistair? Any other reflections or observations?
I think I was just going to say, I think it's such an emotive issue, and I think you're absolutely right, Alistair. It's the thing that people hang on to. It's one of the last things that the relatives can do, and I've often thought that a lot of the issues that arise are maybe around about the communication. If you get the communication right about the conversation you're having with the family, as opposed to, I've always thought it's so much easier not to start with fluids than it is to start them and then withdraw them. But that was more kind of in the acute side. You know how when you go into hospital, the first thing that happens is you get patients get a vein flown, you get a cannula put in. And once there's a cannula in, then it's very easy to start fluids, etc. for IV things. So, but no, I think communication's key. So thank you for that.
Yeah, I think you're right. The luxury, I mean, I have the luxury that the vast majority of my work is either in the hospital or in the hospice. So I'm aware that I get to work in a nice little bubble 99% of the time where I don't have those same challenges of what is able to be provided in the community. So.
Alistair, we've got a question on chat, and so they're looking, the team are just looking for, how would you best work this to a family who are really pushing for subcut fluids? How would you start and approach that conversation?
So, I mean, I say it would depend very much on the individual situation and the patient you've got in front of you. So, you know, if someone is unconscious, unresponsive, and the family are pushing hard for something that I think is unlikely to be of any benefit whatsoever, I think you have to be open and honest about that. I think that I'm probably reasonably, again, this is coming from someone working on an IPU or in a hospital-based setting, if I'm probably reasonably soft on giving it a go if there's a lot of distress around things, because I think it is a fairly low risk intervention. The volume that you infuse is always going to be small, and it's unlikely to cause any major problems. I mean, I think that people talk about whether death rattle is worsened, but actually death rattle is probably a completely different mechanism. And an extra 500 mils of fluid over 24 hours is unlikely to worsen that significantly. Now, if someone is obviously bringing up tons of fluid, then I'm not going to be pushing that. But I think the key thing, if someone is really pushing it hard, is that time limited. You know, if we start this today, we'll give that a go for 24 hours. I'll come back. And again, if I've got that luxury, or I'll get one of the CNS team to be able to do that. And we'll review the situation in 24 hours. If things are better, then great. If things are worse or there's any burden whatsoever, we'll be discontinuing it. But I'm very clear that we will make that call around the burdensome side of things, or if we think we're making things worse. And usually 24 hours, and if nothing is any different, is enough time for you then to follow up. I think if you dig in too hard, you can fracture that relationship. I mean, you could almost say it's like the buscopan and the secretions issue as well. How much of it is about us, how much of it is about the patients, and that's not necessarily the right thing to be doing ethically. So my short answer is case by case, clear communication about benefits and burdens, and very clear communication about review and timescales.
And there's no bad thing, Alistair, in, you know, your clinical work being guided by case, you know, and as you said, it's around about those sensitive conversations and being truthful and honest and giving people the information around that. I think that's absolutely necessary. And you know, the team have said thanks very much for that answer, Alistair. That was very helpful.
No problem.
Thank you. Any other last questions from anybody in the audience before we release Alistair? Anybody, any other burning questions? Things you're not sure about? Okay, I'm going to take that as a no. Alistair, thank you very much for joining us today and providing that very balanced and very interesting presentation. Much appreciated.
No problem. See you all later on.
Thanks, Alistair. Thank you.
Bye-bye. Thanks very much. Okay, everyone.
Yeah, the SOP that Alistair was referring to there about community, the use of subcut fluids is actually on the GGC palliative care website, and it's been relatively recently worked on. So it's there if you wanted to have a look at it. It's on the palliative care website.
Okay, well done to everybody. You survived what has been a very, very busy day. I think you should applaud yourself. A very busy day, forcing you to sit for very long periods of the day, which you're never normally used to doing. So challenges on many levels, but you have did grand, and thank you for that. I suppose it's what's your job now. Over to you is to be really, really open and honest around the evaluations, because it's your evaluations that really help and support any changes going forward to the medicine management days. Really, they're your days. We just facilitate them, but the programme has come up, the programme is devised from what people say is priorities and what they would like to see and hear. So as honest as you feel you can be. And to do that, Jackie's kindly in the chat facility put in the link. So just as we're finishing up, but just prior to that, when we're just about to finish up, if you could click on the link, and then that will take you to do the Survey Monkey, the evaluation on the day. For the people who are sharing rooms, there's a bit of a choice. You can either click on the link, and then when you've finished your answer, you can try and open up the link again. But if that doesn't work, Jackie will happily share the link with you via email. And that's mainly from the PPW side, I think, that we get people sharing rooms. So we can sort that out at our end if it's a problem for you guys. So don't worry about that. But I suppose I just, from behalf of myself and Jackie and also Susan, want to say thank you very much. And Phil, I don't know if Phil's rejoined us again. He was away to a meeting this afternoon, but thank you very much to everybody for your participation and your engagement throughout the day. Sorry for some of the technical issues we had this morning with one of our TV screens, but all ends well. We're all still here, which is good. Susan, do you have anything else to add?
No, I don't have anything at all, apart from I don't think that link's working. So I might need to send you another one, Jackie, to send out by email.
Yeah, if you send it, I'll send it today or tomorrow.
It's saying that we've already taken the survey.
Yeah, there's something wrong with the there's obviously something wrong with the link that we've sent you. So I'll sort that and I'll send it to you this afternoon, and Jackie will send it out to you. She'll email it out to you. If you just keep an eye on your emails, that would be really good, because as Fiona said, it helps us so much to get feedback on days like this. So sorry about that. That's another techie issue. Another techie issue to end the day. But there we go. Start as we start, finish as we start.
There's tech gremlins everywhere, Susan.
Anyway, but no, thanks everybody, and it's been good to see you all, and it's been good. Thanks for participating, because it makes it easier for us as well when you do. So thank you. And I now think you all should go for a big long walk. You didn't do it at lunchtime, you need to do it now.
Take care, everyone. Look after yourselves. All right, lovely to meet you all. Bye bye.
See you later. Bye. Bye. Bye.